CEO, Aventa Jamaica. I would want to extend a very good morning to my dear friend Gita May O'Sullivan, and she will be our moderator for today. I want to extend greetings to the entire Aventa team and the part of Aventa team that's around the Caribbean. I greet you well this morning. I want to greet all our speakers. We have Dr. Terry Baker in the room just now. We have Dr. Jamot. That's all right. That's all right. That's all right. That's quite fine. All right. So, and all my colleagues online, pharmacists, students, pharmacy technician, and just everyone else that is in the hearing of my voice, I greet you very well, and I hope you are having a very good morning so far. My good friend Teddy, over there, big up yourself, Teddy. We have this Virgo, Kitty Virgo, with us. So I greet you all, and of course I must acknowledge the production team, Sam and his team. Good going, sir. As we convene this morning to embark upon this continuing education seminar on the theme Advancing Health, Enhancing Lives, I submit that collaboration is a key element in achieving any kind of success where this is concerned. We're all providers of care, and it is in forging partnership that we will lead a profound improvement in the people we serve. The Pharmaceutical Society of Jamaica's mission is to promote health and serve society as the profession responsible for the safe and effective use of medication, pharmaceutical devices, and services. But understanding the mission is just the first step. We have to move to the execution phase, and this is where we need collaboration. This is where we need all hands on deck. At the Pharmaceutical Society of Jamaica, we provide mentorship for our students and young pharmacists. Our mentorship program is designed to bring the fresh young minds of our students and young pharmacists to align with practicing pharmacists, experienced pharmacists that is in the field, so that we can have cohesion in terms of how we execute the profession of pharmacy. We provide continuing education and professional development for our pharmacists. And this is one of our main drivers for this is our annual conference. And surprisingly, this year we are celebrating our 40th annual pharmaceutical conference. I hear Mrs. Fertility speak about 2025 being a very special year for Aventa. And it seemed like everything she's saying actually aligns with the Pharmaceutical Society of Jamaica, because this year, like I said before, we are celebrating our 40th annual conference. What does this mean? It means for 4 decades, the Pharmaceutical Society of Jamaica has consistently been providing continuing education, cutting edge information to keep our pharmacists in the forefront. Current information. We know knowledge change, we know guidelines change, and we have to keep our pharmacists in the loop, right? And I also want to submit that for the 40 years that we have been providing the annual conference, we have provided over 400 continuing education credits for pharmacists. So it is having an impact. We are in the process of revitalizing our professional code of ethics. And this is important because in any profession at all, you have to submit and adhere to our good professional standards and practice. And at PSG, we encourage all of our members to ensure that they are adhering to the highest quality, the highest standard of professional practice. And this is why we thought it necessary to revisit our code of ethics and ensure that we are bringing it up to our current times, because the code of ethics was written over, well, 1992. And of course, there were things there that we want to look at. There are new things that we may need to add to our code of ethics to ensure that our practice is sound and in keeping with the modern times. We're partnering with our stakeholders to advance healthcare and enhance lives. So, on behalf of the Pharmaceutical Society of Jamaica, I want to applaud Aventa Jamaica for these initiatives and the overwhelming support that you have given and continue to give. I remember the impact program that you did, that you helped to train our professionals, especially those from the Pharmaceutical Society of Jamaica, the committee, to look at management, how we arrange meetings, you know, those kind of stuff. And if we didn't say it before, we really want to say thank you, because some of our members were so excited to be a part of that training. Your choice of theme for this seminar could not be more timely. I say this because the theme for our 40th annual conference later this year is Pharmacists Leading the Future for Sustainable Healthcare. It demonstrates that our collective thoughts are leaning in the same direction. While you are looking at advancement of the healthcare, we are focusing on its sustainability. I want to leave you with this saying. It's an old proverb saying, and it says, if you want to go fast, go alone. But if you want to go far, go together. So I reiterate, collaboration is what is going to bring success as we look to enhance healthcare and enhance persons' lives. Thank you.
Thank you, Dr. Smith. And it is truly a pleasure for Aventa Jamaica to be a partner for you. And in the theme of partnership, I also wanted to take a moment to recognize some of our key partners and our principals who have worked with us over the years to really help develop this business and to offer really high quality products to our Jamaica population. So wanted to recognize Health 2000 Canada, Carile, Ferring, MSD, Beakers, Asa Pharma, Organon as some of our key principals that we worked with. So without further ado, I'd like to introduce you to our speaker for the day, Ms. Gita May Sullivan. And she is a stalwart in the field, well-known and really engaging. So she's going to be partnering with us today with our speakers and just to facilitate the conversations. And Ms. Gita May, she has over 12 years senior marketing experience in the pharmaceutical industry. The last 7 years have been at a strategic business level. And she has particular expertise in international client relationship, having managed houses such as Roche, Bayer, Ferring, AstraZeneca, Wyeth Consumer Healthcare, and Novartis. And she is really skilled in developing and overseeing and documenting the implementation of quality systems in partnership with key international stakeholders. So in terms of her education, she has an MBA from the Nova Southwestern University of Florida. And she has a bachelor's degree in business administration. Now, in terms of her career highlights, just a few. She was a medical representative and then went on to senior medical representative. And she also supported us back in the day when we were Medigrace. So she has been with the family for some time. And she's held various pharmaceutical positions over the years. She has an interest in horticulture, dancing, and singing. And she is a director of GSD Pharmacy. So without further ado, let me introduce you to Ms. Gita May Sullivan, who is going to be our facilitator for the day.
And a very pleasant morning to everybody. It is indeed a great pleasure to be here. I want to welcome everybody in virtual space, and so much so our pharmacists who are on board with us this morning. But before we can proceed, there is a simple test that must be done. And that test is called the lighting up the platform. You know, when you go to those special places and you have the lighter. So we're going to light up the platform this morning. And all I'm asking you to do is to put type 1, because I hear that's the modern thing. Just type 1 in the chat feature. And so I'll ask Sam, who is here, to tell me, why to light up? Light it up this morning. Absolutely. I love it. We are on target, Kirk. We're doing it right. Yes, and boy, I don't know how to tell you to stop now, because it light up proper lighting up. And Sam, do we have the opportunity to ask 7? Yes, thank you. Do we have the opportunity to ask to open mic, to unmute? We're going to ask this morning one question. And the person who answers the question correctly has a gift basket to get. And that person must be able to unmute Sam and say good morning in French. Raise your hand. Raise your hand. Raise your hand. Raise your hand. Delina, open your mic. Let's hear you.
Bonjour. Bonjour.
Haha, clapper in this space. Fabulous. That's what we're about today. We're going to have fun. We're going to get some real good information. We are going to be better off when we're finished. Aventa will be giving away 15 early bird baskets. And by that, we mean those persons, the 15 persons who registered first will be winners of the basket. But here we go. That you must be online with us, because I am going to announce the winner after every spotlight. So I'll call 3 names and you will know, and you will receive your baskets, because we know the pharmacies that you're aligned to and we will deliver them. So as I get us warmed up and ready, anybody who knows me will know that I'm going to tell you that scripture says that this is the day that the Lord has made, when in one place an excess of over 750 pharmacists can be gathered on 2 platforms soon, because if you break the 1,000 mark, we are going over to YouTube. So this is a time when we must rejoice and be glad in it, because this morning is a first. It's a first in many ways. It is a first Aventa CE. And so for that, we are grateful. It doesn't get any better when we can learn with each other in conversations with great people on this platform. And we are going to be exposed to some of Jamaica's top presenters in the areas that they are expertise and experts in. So we are together, and today is about conversations. We are here, we'll be exposed to what's in the air. We will be knowing that at a time when there is an egg crisis, there's an egg crisis in Jamaica and in the world. In the food industry, we will be entreated to knowledge on how to freeze social egg. Get it right. It's not egg to eat, it's social egg in the reproductive sphere of our life. Then we're going to be entreated to the story of our life with pharmacovigilance. And we need that, because the business must be run within certain parameters. And we will be waiting on, with a bated breath, the OTC reclassification. So stay tuned. Let's begin with a few housekeeping highlights. Sam tells me all mics will be muted and reopened only when he dictates. And if you're going to chat with us, put your questions and comments in the chat. And that will be it. Sam, I'm good to go. I thank you. So that's our welcome aspect. To speak on the topic of what's in the air, an update on emerging respiratory viruses, is our Dr. Terry Baker. This topic is so befitting at this time, having gone through COVID, and we're faced with Sahara dust, among other phenomena. Dr. Terry Baker is no stranger and is our consultant pulmonologist and senior medical officer at the National Chest Hospital. Her area of expertise sees her specializing in pulmonology and internal medicine with a focus on treating chest-related illnesses. It's worth mentioning that Dr. Baker's expertise, her passion about educating the public on the risk of smoking and secondhand smoking, and her oncology work in lung cancer symptoms will provide us today with the requisite information on what's in the air. Dr. Baker, we welcome you.
Good morning. It is certainly a pleasure to be here this morning. I cannot imagine that there are over 700 people online. 840. Oh my goodness, it's 840 and counting. I would like to take this opportunity to thank Aventa Jamaica. I'd like to take the opportunity to thank Karen Kelly to invite me to such an auspicious occasion, and I only hope I will do it justice. It's wonderful being here because I have the opportunity to see friends and faces I haven't seen in a while. So without further ado, we're going to get to our topic today, and it's what's in the air, the emerging respiratory viruses. And as Lisa May has said, since COVID-19, we have all been on a heightened level of alertness as to what is happening. So looking at the agenda, we're going to be reminding ourselves of what is a virus, right? Because we get sometimes a little muddled between virus and parasite and bacteria and what can treat what, right? We'll then look at, generally speaking, an overview of respiratory viruses and disease, looking at the modes of transmission of respiratory viruses, what are some of the risk factors, and a general overview of drug therapy, particularly looking at viral infection. Then we'll pay a little attention to some of the emerging respiratory viruses out there. So we do have a few questions in between, and we kick off with our first question, our first poll question. We have about 30 seconds to answer. So the question, I hope you can all see, viruses do not need a host to multiply, but rather can multiply on surfaces such as counters, the toilet seat, the sidewalk. Is this true or false? We have just a few seconds to answer. Ten seconds left. I'm expecting to see nearly 900 answers. I think that was a relatively straightforward one. So let us see what our answers look like. We are about 50-50. All right, we'll see where we go. So the operative word there, I think, is multiply. So when we look at a virus, it is an obligate intracellular parasite, means it has to live within a cell for its life to continue, and by continue, I mean for it to multiply. So even though a virus may be on a surface, it may sit there for hours, days, weeks, right? Months even, but it will not be multiplying. So in multiplying, I mean to produce more viruses, right? And for that, it requires a host, it requires a cell. And these viruses are thought to be some of the oldest organisms out there. They were there from the time of creation. They are relatively simple in their genomic structure. They either have RNA or DNA, but by no means do they act as simple as they may look. So for propagation, they require a host cell. And what the viruses do is to inject themselves within the cell. They then release their genomic component and uses the cell to multiply and produce further viruses that then destroy that cell and move on to other cells within the host, wreaking havoc in many instances. So the answer to that question was that it was false. Viruses do require an intracellular host and cannot multiply on surfaces. So when we look at respiratory viruses, so why is Aventa? Why are we even going here? Well, we know it's a major global health concern due to its widespread prevalence. I mean, all of us know somebody right now that's having sore throat, coughing, sneezing, and having difficulty breathing in some instances. The viruses, though, are often self-limiting. And many times when I have a patient in front of me coughing, I say, not to worry, you're doing fine, it will go. And often it may be confined to the upper airways. However, these infections can cause severe lower respiratory tract diseases, such as a pneumonia, a bronchitis, a bronchiolitis, right? So while most of them may be self-limiting, we need to remember that they can wreak quite a bit of havoc within our bodies. So how does transmission occur? Usually through inhalation of these airborne particles. So when someone has a viral infection and they're coughing, they're sneezing, they're singing, they're chatting, and not using proper practice to cover their mouth, cover their nostrils, then these particles are airborne. Either the person who is close to them is then infected by these particles, either dropping on their skin, on their mucosal membrane, such as their eyes, their lips, and then they inhale in some instances, or contaminated surfaces. So we all know the kids that we tell them, listen, don't share your water bottle when you go to school, right? Because of this very thing, because of the viruses that can then live on these surfaces and be transmitted to another. So we have host factors, seasonal and environmental factors that basically influence the incidence and severity of respiratory diseases. So the thing about a virus, I consider them some of the smartest organisms out there, because individuals who are infected are oftentimes contagious even before they develop symptoms, and they can remain infectious for several days after symptoms appear. You hear somebody say, but doc, where I get this from? Nobody around me was sick. Nobody around you that was sick that you could appreciate, that you could see, or the person themselves may not have had symptoms, but yes, they were there transmitting it. And this is some of the concern why we see propagation and why we have these super spreaders that are out there. They may not have much symptoms, but they are definitely spreading it. And there are immunocompromised individuals. And I'm here to say, many times when we talk about immunocompromised, we start to think about persons who are infected with HIV. But that, I will tell you, is the smallest group of immunocompromised persons. Persons who may have chronic conditions such as diabetes, persons who may have underlying cancers, malignancy, persons who are on certain medications such as steroids, and we have a lot of persons on, and I'm talking particularly systemic or oral steroids, or persons who may be on these highfalutin drugs that we have nowadays, all the MABs, the refluximab, the whatever MAB, all these MABs, right, impact their immune system. So most RVs will trigger an immune response within the epithelial cells of the respiratory tract once infection occurs, and by that way they basically bring about their mutation and their inflammatory response, leading to disease. I mentioned about transmission, just to look at it briefly. You can have transmission from one person to another by various modes. There may be direct contact or indirect contact. This is when you have the contaminated surface. Droplet sprays, so these are larger droplets that you won't necessarily inhale, but they then drop onto the surfaces or drop onto somebody's skin and then or hands, and then they use that hand and rub their eye or rub their nose or hands in the mouth. And then you have aerosolization, which are particularly smaller droplets that if you are in the presence of someone who has a respiratory illness and they're coughing, etc., and there's aerosolization, then you can inhale those particles that would have the viral components to it. Some of the host factors that we look at are age. So there are two extremes of age, are the more susceptible, so are young and the elderly. Persons with I hear I was on a cell phone and think I'm talking and nobody hearing, but let's continue. Host factors, the age, medical conditions, immunocompromise, and as I say, not to be left out, are lifestyle. Lifestyle choices, such as smoking, which would impact our airways, reducing our ability to fight infections, our diet and lack of exercise also puts us at risk. Environmental factors, you know, there was a time it said rain going fall, you need to come inside because you're going to get a cold, and somebody would say, but after the virus, not in the rainfall, what you're talking about? But you do have studies that show that changes in humidity, rainfall, temperature will impact viral ability to multiply, to mutate, and to infect persons. So we need not scoff at what our parents and grandparents used to say, that indeed, when there's rainfall, when it's more wet, when it's more damp, and some of this may be seasonal, then we do get an uptick at times in the number of viruses and the virulence, that is how aggressive the viruses can be. This may differ between countries and even within a country in locations, but just to underscore that it is not to be ignored. Sorry. Ventilation and air pollution, such as more time spent indoors in closed environments during when you have these cold or rainy times, when we have the Sahara dust and you're telling persons stay inside, don't go outside. Oh, doc, I'm going to exercise early in the morning when it's nice and cool. No, the dust is still out there. Exercise within, because it affects your respiratory system and weakens your defense system to fight an infection. So we have an interplay between host factors, environmental factors, and the virus itself that puts us at risk of having a viral infection. So this is just a diagram showing inhalation of various respiratory viruses, whether it be SARS-CoV, which is COVID virus, the RSV, respiratory syncytial viruses. It enters the airway. Now we only have one airway. We don't have an upper and lower because it's a continuous tract. Yes, it may affect primarily the upper section, but if not controlled there, it will go down to the lung, or it will instigate an inflammatory response. And when this inflammatory response is dysregulated and exaggerated, we have what we then call a cytokine storm. We may remember that word from COVID-19 when people were talking about cytokine storm. So it's like the whole immune system got a little berserk. And because of that, we have other systems that are now being affected: brain, heart, kidney. So you have this heightened fever, this heightened feeling unwell. And as I said, you can have other systems being infected, because once the virus invades the epithelial cell within the respiratory tract, it then incites this heightened immune response. So when we look at therapy, we've looked at the virus, but how are we going to treat it? So what the viruses do, what the antiviral therapy does is basically directly either target this virus or components to suppress its activity. But remember, I said that these viruses are obligatory intracellular organisms. So to do so many times, it has to enter the host cell as well. So they typically interfere either with the entry of the virus within the host cell or by its replication by disrupting the virus's internal machinery. And you have a number of different types of drugs. And a lot of this work has come out of HIV and the research that has gone into HIV and the development of drugs that attack the virus along its multiplication pathway, looking at various enzymes and its ability to attach to cells. So some antiviral agents will target what we call the spike proteins, which is what the viruses use to bind to cell, and in so doing, viral entry is prevented. I won't spend long time here because what this is just showing you is a cell with a virus that has entered. It has basically broken down, and you have multiplication of the viral genetic material taking place. And the red boxes show various areas where it is that drugs can be targeted or used to prevent the replication of the virus. So let us get to what we are here really to look at, emerging respiratory viruses. And when we speak about emerging respiratory viruses, we are speaking of viruses that have recently appeared in a population, or they may have indeed been there before, but now they are increasing in incidence or geographic range. So more places, more countries are now experiencing these viruses. They can originate from animals, what we call zoonotic infections, or from mutation of the pre-existing virus. And they have the potential to cause widespread outbreaks and pandemics. We have just come through COVID-19 pandemic. I'm certain all of us are grateful that we are here. We have not forgotten it. I personally would like to live a long, healthy life, and I don't want to go through another pandemic like that. But because of how smart viruses are, there is a real potential, and I'm not here with any conspiracy theory, there is a real potential of another pandemic. So we're going to be looking at a few of these emerging respiratory viruses, and one of the first one is SARS, or severe acute respiratory syndrome viral infection. So SARS was the first severe and readily transmissible new disease to emerge in the 21st century, right? And it was spread through, and remember I spoke about droplets, contact, etc. Well, this was spread through aerosolization of small infectious respiratory particles, and then you had the infected persons and the super spreaders who may not have had much symptoms, but they were going all over, going into parties, going into infirmaries, going into hospitals and spreading this disease in which the mortality rate was quite high. It was first recognized in China, right, and it spread rapidly to 29 countries within 5 months. For SARS, in 10 to 20% of cases, the respiratory illness was severe enough to require intubation and mechanical ventilation. So you have 100 people infected, 10 of whom it is estimated will require ICU care. It was rapidly fatal, and mortality rates were up at about 10%. And a disproportionate number of deaths occurred in the elderly and in those persons who were immunosuppressed. Thankfully, although they did report a few cases in children, for the most part, were relatively spared. Some of the symptoms noted would have been a persistent fever, chills, headache, body aches, cough, diarrhea, sore throat. So this looks like nearly any other respiratory viral infection. But the fever itself associated with SARS was something to be to take note of. It was persistent despite many times antipyretic measures. So antiviral therapy was adopted even before they identified exactly what the virus was, because the thought was that whatever was happening here must be a virus. And they never had much, right? Ribavirin was chosen. It wasn't really effective. Corticosteroids were used, and actually in some cases, both of these drugs made the outcome worse. So a lot had to deal with symptomatic supportive treatment, that is antipyretics, IV fluids if required, antiemetics, non-invasive positive pressure ventilation using things like a BiPAP mask to really deliver oxygen, and intubation for those who required it. So that, in a nutshell, was the SARS virus. We're going to look at H1N1, and I dare say every year we hear, so boy, swine flu is here, swine flu is here, swine flu is here, and everybody getting, uptight about H1N1 influenza and the swine flu. It emerged as an epidemic really in 2009. And the thing about the swine flu is that pigs actually have had influenza H1N1 as far back, documented as far back as 1930. But it was in 2009 that what we saw was a virus that took particles from the prior swine, the prior avian, and the prior human influenza, and just merged everybody in. And this is what is frightening at times about viruses, because they do mutate and they do change ever so often. It is an influenza A virus, just to say for the influenza viruses, you can have A, B, C, and D, of which A, B, and C are those that commonly affect humans, particularly A and B, and it is the influenza A virus that really mutates quite a bit. It too is a RNA virus, just like the SARS virus that we just spoke of. Indeed, in this century, the respiratory pandemics and epidemics that we have seen are all RNA viruses. So just to take note of. It is less deadly than other pandemics, but those of us who have had influenza know it is extremely uncomfortable. You may have the fever, the sore throat, the muscle pains, the joint pains. So even though it is less deadly, you do have every year quite a number of persons who we lose or who die because of H1N1 infection. And in 2009, when we had the pandemic, it is estimated that we had over 150,000 to over 500,000 respiratory and cardiac deaths within the first year of the population. Based on their projections, it is estimated that up to 24% of the global population may have been infected with the H1N1 influenza virus. It is a zoonotic virus, because even though you will have now human-to-human transmission, the initial virus did take its components, as I mentioned, from the swine as well as from the avian virus. So the infectious period, that is when the person is shedding viruses, occurs about a day before the symptoms develop and lasts up to a week after the development of symptoms. And the person may actually, in children and in immunocompromised persons, shed that virus, be infectious for even longer. Mentioned, it is mostly self-limiting in healthy individuals, but you do have persons, because of their underlying conditions and age, that it may cause more severe disease requiring hospitalization. So the high-risk groups that were identified would have been the pregnant women, especially those in the first trimester, children under the age of 2, individuals with chronic lung conditions, and I want to take the opportunity here to include asthma. Because while it is, we say, yes, asthma can be controlled, and you don't outgrow asthma, it may remain quiet for many years. Asthma is a chronic lung condition. And we spoke about the immunocompromised before. So treatment is oftentimes symptomatic. In mild cases, you know, you take your chicken soup, your orange juice, you lay down in bed, you take your antipyretics, right? For symptoms, or if you have nasal congestion, some antihistamines. Those persons who are more ill may require hospitalization, and some actually will end up in the ICU. They may require oxygen therapy, IV fluids, and antiviral therapy. So when we speak about antiviral therapy for H1N1, we're speaking about getting to these persons early. Within 48 hours of the onset of symptoms is when these drugs are most effective. Here in Jamaica, I'm aware that we've had the oseltamivir, that is the Tamiflu. I don't know of us having zanamivir or the peramivir. And I have seen an uptick or an increased usage of the oseltamivir, particularly since COVID. More persons having had flu-like symptoms are asking for it. But just to recall that these drugs do have side effects, and it is not just a matter of prescribing it and the patient going off, but the patient as well should be monitored. So yes, we've had the H1N1 swine flu, which is a zoonotic infection, but you actually have new strains of influenza out there, and they too seem to be zoonotic in origin, coming particularly from birds. It is to say that as these viruses mutate, we need to have vigilance and to keep our eyes on them because of the potential of having an epidemic, or worse yet, another pandemic. Let us look to the Middle East. We're going across the other side, but so many of us travel all over the world nowadays. We don't live in a vacuum. So you have MERS, Middle East Respiratory Syndrome, and it too is one of the SARS infections, actually. It was first identified in 2012 in Saudi Arabia. It is a type of coronavirus. When COVID came up, people thought that COVID was the first coronavirus. No, we've had coronaviruses out there from before. It too is a zoonotic disease, most cases linked to camel exposure. So here I am saying, okay, we don't have any camels in Jamaica, but indeed we do. We do have 1 or 2 places that have camels, right? So we need to be mindful. Not to mention, we have people going to the Middle East all the time. So going to the Middle East, and it is an experience to go and ride a camel, just to be aware that if the camel is not well, because many times the animals are not well, you need to stay away. Human-to-human transmission is not common. It has occurred predominantly in healthcare settings, but the disease itself can be quite deadly. As of April 21, 2025, there have been about 946 associated deaths, and the majority of these have occurred within that Arabian Peninsula, particularly in the Kingdom of Saudi Arabia. And the mortality rates can be high, up to 35%. So it's not to be scoffed at either. Those persons who are at increased risk mimic or are similar to some of our other viruses that we just mentioned: older persons, persons with chronic diseases, persons with renal, chronic lung disease, hypertension, cardiovascular disease or diabetes. And if we take hypertension, cardiovascular disease, and diabetes and plug that into our population, we're talking about 40–50% of us, right? So we need to be mindful, particularly as people travel back and forth. The symptoms range from completely being asymptomatic to a severe acute respiratory disease and death. Again, fever, cough, shortness of breath, pneumonia, and gastrointestinal symptoms such as nausea, vomiting, and diarrhea. And as mentioned before, you can have severe diseases causing respiratory failure. So treatment, there's no vaccine or specific treatment for MERS. A lot of it is based upon supportive care, IV fluids, analgesia, antipyretics, oxygen therapy. They have looked at vaccines and emerging drugs, but there is no one drug as yet identified for the management of MERS. Moving ahead, we're going to go to RSV. And this year, we had quite a bit of discussion right here in Jamaica about RSV viral infection. So I think we have another question coming up. The respiratory syncytial virus is a zoonotic disease from cats and dogs. Is this true or false? And we have 30 seconds. So just answer for me, please. Is the respiratory syncytial virus a zoonotic disease? A disease that has come from animals? Yes, let us see what we thought. Okay, again, this looks like a mirror of the last question, right? All right, let us see what we see coming on. So we have yet another question, right? We'll get back to the answer of the first one soon. Respiratory of RSV, this is a respiratory syncytial virus in a 30-year-old adult with no chronic illness. What would you use? Oseltamivir, which is the Tamiflu, RSV vaccine, all of the above, or none of the above? You see, this question is so designed because when I was in med school, when you see all of the above, you tick all of the above. Or when you see none of the above, you tick none of the above. But now you have both. So we need to think, right? Okay. And then we're going to go to the question, the answer again. All right. None of the above. I gather my time is up, so we're going to speed through, right? So this has become a virus of significant concern, particularly in young children and the elderly. And it does cause a number of hospitalizations, and it is the leading cause of hospitalization in children, most of which occur in low and middle income countries. There's a seasonal timing of it, and usually starts in the fall and peaks in the winter in the US, but here in Jamaica too, and in other countries that don't have a true season, we're seeing where we have a time of the year where we see an uptick in the number of cases. These are the symptoms, again, very much similar to symptoms of many of the other respiratory viruses. However, this one oftentimes will come with wheezing and then with bronchospasm in someone who may never had wheezed before. Risk factors are very similar to other risk factors, but including those who are in infirmaries or in nursing homes, or who may have neurological or neuromuscular diseases, and for them, they're not able to actively clear well the mucus that is being produced. So, looking at our question, the CDC recommends vaccination for adults 75 years and older, and for adults 60 to 74 who are at increased risk. There is also a vaccine that may be given to pregnant women and a monoclonal antibody which can be given to the infant at birth. The RSV virus is not a zoonotic disease, right? Let us go to SARS. Another question. SARS-CoV is the deadliest infectious disease. We're going to cut down the time, only 15 seconds to answer this. True, false, or just don't know. Let us see what the answers look like. I like the honesty of the persons who say they don't know, about 17%. So this is a bit of a quirky question because SARS-CoV did outstrip tuberculosis as being the deadliest infectious disease and even HIV. However, as of November 2024, tuberculosis reemerged as the deadliest infectious disease out there. So SARS-CoV has no longer has that #1 spot. Second question, SARS-CoV is a zoonotic disease caused by 1, wild bats, dogs, chickens, or none of the above. What say you? Again, 15 seconds. We need a deputy. So let us see what the answer is. I like this. We still have some who say wild bats. And with mostly just above 50% saying none of the above. And the correct answer is none of the above. SARS-CoV actually has been classified by the WHO as a zoonotic disease of unknown animal origin. So that has caused a lot of stir and a lot of discussion. Just to go to the wild bat story, we know where that was coming from, but you do have coronavirus, SARS-CoV viruses out there that do have components that are also seen in coronaviruses affecting bats. So it began in 2019, we know again in China, declared a pandemic March 11 by WHO, and Jamaica recorded its first case on March 10. Needless to say, even though many people get so uptight about COVID virus, and with justly so, just to underscore that the majority of persons will have mild disease. However, because it was a novel virus, a brand new virus for us, a lot of people ended up ill. And so when you think that only 14% of patients will develop severe symptoms, that is still a large number. Incubation period is 4 to 5 days. Infection can last longer, right? And evidence suggests that the viral shedding and the period of infectiousness, like other viruses, is longer in persons who are immunocompromised. And transmission is via droplets or aerosolization. The thing about COVID-19 is that the symptoms often change depending on the variant that is out. And they have over 1,000 variants. You have variants that are now mutating with themselves. So that sounds a little near wrong to me, but you have one viral variant and another viral variant mutating and coming up with a new one. Now, a lot of people, the most recent variant that is out is the 1.81. It is also called Nimbus, right? Causing a lot of sore throat. They cause it the razor pain to the throat. And you have a lot of people now complaining of this sore throat. But as I said, the symptoms and signs are often determined by the variant that is more prevalent. There are some symptoms and signs that will persist, such as the fever, the headaches, body aches, but such as the diarrhea, we saw more in the Delta. I think it was that we had more diarrhea with that variant. You do have persons who are having diarrhea with the Nimbus. Complications include nearly every single organ, from head to toe, inside and out, because you have persons who have had alopecia that has been linked to COVID-19, cognitive impairment, stroke, blood clots to the lungs, acute kidney injury. cardiac injury, dermatological manifestations, ongoing lethargy, chest pain, fatigue, loss of taste, loss of smell, and long COVID. Care, supportive care, the antipyretics, oxygen therapy, drug therapy. A number of drugs came on, and some of them I will not mention, like the hydroxychloroquine and the ivermectin. We won't go there, but dexamethasone is still indicated for patients who are hospitalized with hypoxia. You do have the Paxlovid that I don't think we have it here, but this is for patients with mild to moderate. The US had a program in place once. If you go to a pharmacy and you tested positive and were at risk, you would get the Paxlovid. Remdesivir was also available here. Remdesivir has found favor, lost favor, found favor in terms of managing patients with COVID-19. WHO had taken it off the list at one time. It is now back, but with riders, early onset, and persons who have moderate symptoms, because it reduces the risk of serious illnesses. Molnupiravir is basically approved in Canada. The US is still hemming and hawing about it. And then we all knew about tocilizumab. Vaccines would have been a big area more for prevention. So we're winding down because I know I'm way past my time. We're looking at the upsurge. So the question is there truly an upsurge in respiratory viruses? And we could stay here all day and just look at this one slide and have a full discussion, because you have governmental agencies in a number of countries that are saying as of June 2025, we don't have an increase in numbers. That what we're seeing now is what is to be expected. Now, they have all sorts of epidemiological models that they're looking at, and I'm not going there with you, Teddy, I'm not going there with you this morning to discuss that aspect. Now, the question is there a seasonal increase? So we do know that coming on to when we start to get more rains, coming on to the September, the October, the December, we will get an uptick. So people are saying, no, when outside of those seasons, we're not necessarily seeing an upsurge. There's a lack of hard data. For our cases here in Jamaica of COVID-19, for example, I will say, just take that number and multiply it by 10, because you had many persons who were not going to get tested, many persons where the test just seemingly disappeared into space and you just don't know where it turned. Many people still waiting on results and don't know what it was, right? So we don't have hard data. A lot of what we're seeing is more observational, anecdotal. And the question is, are we looking for it more? Having gone through COVID, if somebody beside you sneeze, now you pull over, right? And somebody else sneeze, are we looking for it more? And that's why I said we could discuss this till the cows come home. Interestingly, and not unexpectedly, I would say, there are lower vaccination rates in adults. In 2025, the US had an increase in terms of influenza. People will say, but we were locked up for so many years, everybody wearing masks, nobody coming out and seeing anybody. Once we come back out and take off the mask, then we opened up ourselves to becoming infected. But this year in the US, when they aim for a 70% or more in terms of influenza vaccine, they were at about 44%, way below their target. And I won't even go there with Jamaica, because even as healthcare professionals, I know many of us have not taken the vaccine. So there's a lower vaccination rate, vaccine hesitancy, and I will dare say the whole debacle of vaccines and COVID-19 has more or less muddied that water. So persons are hesitant about moving forward. Climate change, I mentioned the humidity, the air pollution, the areas that were once damp are now dry, areas that are now dry, were once dry, are flooding, and lifestyle changing. And then the increasing human to animal interactions, right? A lot of which it opens the door for zoonotic infections. So you have more persons There's somebody very dear to me, and she sent me a picture with her and her dog in the bed. Right? So even though domesticated animals themselves can have viral infections, and then you have greater interaction in some countries with wild animals. Are the lungs susceptible? Yes, they are. Right? Because it is the area you inhale. The nasal passage can be affected in terms of lowering its resistance and its function to fight infection. And we do know once it hits our upper airway, it can then progress to the lungs and cause a pneumonia. The lower respiratory tract infections are the greatest cause of infection-related mortality and rank 7th among the leading causes of death in the US. So in conclusion, I'm finally there. Emerging respiratory diseases are often driven by novel pathogens, changing environments, and increased human-animal interactions. Treatment is often supportive, symptom-driven, because we have limited specific antiviral drugs, not to mention the cost. Vigilance, surveillance, and a rapid response and global cooperation are therefore essential to mitigate their impact and protect global health. Thank you.
Okay. All right. So we have a few questions here online. First question, is there a current variant of COVID virus that is markedly virulent in the US of A?
So the US recognized just a few days ago about this new variant that is out. It's called the Nimbus, and some of them now just have letters because depending on what classification you're looking at. So it's I think it's the N1.8.1 viral variant that is out. It does come with a severe sore throat. It does come with the fever, the malaise, and really feeling quite unwell. So yes, there is a relatively new variant that is out. I don't think we are doing variant testing here, but it is no surprise as we travel so often that if we don't even have it yet, and I suspect we do, we'll have it shortly.
Thank you so much. Dr. Baker, do we have the capacity to do testing for antiviral substances here?
Antiviral substances?
That's the question.
So when we look at viral infections, I mean, yes, we look at the respiratory viruses, but remember we had CHIKV and ZIKV, and every year we have dengue, right? So we have the capacity to investigate for some viruses. Now you have tons of viruses out there. We will never have the capacity to check for all, but I do believe, giving kudos to the various authorities, that we do have the capacity to test for some of the more relevant and infectious ones here, and have arrangements if needed to send samples overseas.
Thank you very much. Paxlovid is now registered in Jamaica and will be available soon. That's not a question. What is happening in Jamaica with respect to tuberculosis?
Okay. So tuberculosis is actually a bacterial infection. So we've sort of focused on viral infections, but you do have important bacterial infections as well that affect the lung. Of course, tuberculosis is one. And I did mention that for a short time, or during the time of the pandemic, COVID-19 outstripped tuberculosis as being the deadliest infectious disease. So tuberculosis is back on top. In Jamaica, we've always had tuberculosis. You know, some people say, really? I say, yes, we've always had tuberculosis here. We have on approximately 100 cases per year. Each person has the potential of infecting another 15 to 20 persons. And there's nothing that you're going to look at somebody and say, this person has tuberculosis. Because a lot of the respiratory symptoms are similar, except that TB may have a longer protracted course. You have some populations that are at increased risk. The lower socioeconomic groups, persons who are institutionalized, whether it be in jails, prisons, or infirmaries, would be at increased risk. So we always have to have our surveillance up. And every now and again, we'll have an uptick in the numbers, but we sort of approximate around that 100 to 80, anywhere from 80 to 120 cases per year.
Final question, I'll merge two. COVID test kits, the in-home COVID test kits, are these able to detect the newer variants of COVID? And what's your feelings and thoughts on supplements like elderberries, vitamin C and D to treat?
So when COVID first came out, we threw the kitchen sink at COVID-19. Anything that could work, try it. Let us see if it worked, right? Let me take the first part of the question in terms of the kits. A number of the kits that are here in Jamaica are outdated, right? Because there was once during the pandemic, everybody was taking in kits to have the testing done. So if you're going to use a kit here, you have to check the expiry date on the kit, because we've had persons coming and saying, oh, but I did the test and it came back negative. You do have some kits, and I don't know of any brands that people are using and it has come back positive and also negative. But remember, any test, you can have false positives and you can have false negatives. A test is not taken in isolation. You have to look at what is happening with the person in front of you. And if needed, then go on to PCR testing. The second part of the question was?
Use of supplements.
Supplements? Well, so as I said, COVID-19 brought us to our knees and recognized that diet, and with diet comes minerals, right, are important. So it has been shown that elderberry, vitamin C, zinc may actually improve and strengthen the immune system. So persons use it. Have I told my patients to use it? Yes, because it may help. Chances are it's not going to hurt, right? And you have so many other things out there. You have people talk about ashwagandha, all sorts of things to take. And so, as I said, taken appropriately, because that is sometimes a big question, it may help and is unlikely to hurt.
All right, thank you so much. Give her a round of applause. Thank you, Doc. You should stand.
Dr. Baker, on behalf of Aventa Jamaica, we'd like to give you this token for appreciation. Very insightful presentation and very informative, and I'm sure the audience agrees as well. Thank you very much.
Thank you. My pleasure being here.
Good day, everyone. Welcome to the Carile family of products. I'm Tiffany.
And I'm Shakira.
And we're part of the Carile Medical Representative team.
Let us take you on the journey of Carile and our quality products.
Our state-of-the-art machinery, facilities, all in Barbados.
As you know, Carile is committed to providing Jamaica with safe, efficacious products of the highest quality at affordable costs. Please see our range of products.
Tuscased Lintas.
For your non-productive cough.
And as you know, we have Tuscased EF.
Our ephedrine-free formulation.
What about our Brohex?
That's our sugar-free mucolytic.
And everybody knows the famous. What's the famous, everyone?
Histatussin, of course.
And as you know, it's our bestseller. Then, as you know, with Histatussin, there also comes Histatussin
DM, followed by our very own Histal Elixir.
For all your allergy relief.
Our Histal Expect.
Our very own expectorant.
Sugar-free, of course. And our Histal DM.
Our non-drowsy cough suppressant for everyone.
Then we have our Histal DC.
Our decongestant.
And our very own Dica.
Which you know is our antacid.
And
It's summer and it's hot. Feeling a little lethargic?
Why not grab a Bicoplex? Packed with all your B vitamins and a little bit of C to give you the boost you need.
But that's not all. Bicoplex also comes with a combination of iron. And guess what?
It comes in both liquid and capsule formation. Enhance your mental and physical performance and increase your metabolism and accelerate growth with Bicoplex.
So we're back with you again, and I promised that I would release the name of those persons who registered first, and I want to let Jadon Salmon know that, yes, we have Jadon Salmon, Kristen Atkinson, Kim Wright, and Jessica Johnson Graham. And as we get to the next sponsors I highlight, I definitely will be telling you who are the other persons who are recipients of our wonderful Aventa baskets. I wanted to say something. Viruses travel without any immigration challenge, and ICE can't run them down. Here we go. We are going to get into our next speaker, and we're truly looking forward to her having had Dr. Baker deliver so well. Aventa has decided to include a topic on fertility in this CE event, as this is becoming increasingly topical in the last few years. Many countries, including Jamaica, are facing declining birth rate and worrying trend. There's a worrying trend as nations grapple with how to maintain a sustainable and productive workforce. The issue is multifactorial and includes clinical infertility, couples who face difficulty conceiving, their social issues, the Gen Zs who are pursuing careers and delaying childbirth. I'm not a Gen Z. Abortions, clearly. Changing family structures, just to name a few of some of the social issues. So it's very timely for us to hear a lecture from Dr. Frederick on social egg freezing and surrogacy, the viable options to preserve fertility. Dr. Sharifa Frederick, a consultant OBGYN, fertility specialist at the Caribbean Fertility Center, and is one of the Caribbean's expert voice in fertility-related challenges. Her passion for this field in medicine sees her spending most of her time and days at the Hugh Winter Fertility Management Unit. Today, she speaks to us and shares with us her expertise. We welcome you, Dr. Sharifa. It's a pleasure.
Morning, everyone. Morning, everybody. Thank you for giving me the opportunity to speak today about a very topical issue, egg freezing and surrogacy. And it is very timely, as was mentioned prior. These modalities will help to tackle our decline in birth rate. In Jamaica, our birth rate is currently 1.9, and the birth rate to replace the population is 2.1. So we can see that we're underscoring in this field. So I will talk a little bit about egg freezing and surrogacy today. Okay, so egg freezing. So what I'll speak about, my objectives today are to define what is egg freezing, social freezing, and medical freezing, define and discuss infertility and the rates in Jamaica, explain the importance of egg freezing and the social reasons why it's necessary, outline the steps for egg freezing, define surrogacy, and outline the steps involved in surrogacy. Okay, so egg freezing is done for two major reasons. It's done for social freezing, and this is done in healthy women who wish to preserve their eggs for future use. So there is no medical indication in this category. It's also done for medical reasons, for women who are undergoing cancer therapy, whether it is to remove the organs or to get cytotoxic treatment for cancer. And so they should preserve their eggs before embarking on this treatment. We have something called low ovarian reserve, which it has thwarted even young women, and it's called premature ovarian failure. And once a woman does or suspects that she may have a family history of poor ovarian reserve, or she may have a condition that may predispose her to a decline in ovarian reserve, such as endometriosis. And sometimes just a random test by doing an anti-Müllerian hormone test, a fertility test, one can know that their fertility reserve is being compromised and they should freeze their eggs for medical reasons. There's also the other area of transgender prior to medical transitioning. Okay, so when should egg freezing be done? Ideally, it should be done before your ovarian reserve starts to decline. And this is before the age of 35. It can be done older, but you get the best results if it's done in an age group of less than 35. So the best result is between 25 and 35 years of age. Sometimes, but the reason why we put 25 is that in certain young women, it's a challenging procedure, and you really don't want to predispose a young person to this sort of procedure too early in life. When you get an egg yield of between 15 and 25, you will get a greater success, and this may require more than one treatment cycle, however. Why should somebody freeze their eggs or undergo fertility preservation? It is done in an effort to prevent childlessness and to prevent infertility later down in life. That's the only reason. Okay, so what is infertility? Infertility is defined clinically as not being able to achieve a pregnancy after 1 year of having unprotected regular intercourse, or after 6 months in the older woman, in a woman greater than 35 years of age. So you don't want to leave a woman who is over 35 trying for more than 6 months if she's unsuccessful. Now, the worldwide prevalence of infertility as of 2023 was reported by WHO to be 17.8% in the high-income countries and 16.5% in the lower and middle-income countries. And this lower percentage could be because of decreased access to care. In Jamaica, as of 2002, the impaired fertility rate was about 31%. This doesn't just include the inability to conceive, it can include miscarriages and abortions, etc. Now, this slide, I think, defines the real importance of egg freezing. Nowadays, we have a global shift in the age of childbearing. We find a lot of women are trying to conceive in the 35 and over age group. Young women, some of them don't want to have children right now. They don't want to have children at all. And they're postponing childbearing because they want to expand their formal education and because of economic uncertainty. So we have a lot of women in their 20s, they're just not interested in conceiving. And I think that age group is important for them to freeze, because even if they don't want to have children, they think they don't want to have children, they should still preserve something just in case they have a change of heart later down in life. Now, the problem is that in the younger age group, they're not really trying. But as you can see, the per month chance of conception when you are in your 40s and older is very low, as you can see on this chart. Right? So here lies the problem. Now, when we look at the patients who are coming to the IVF clinics, we looked at some women from 2023 to 2025, and we see that 50% of the women who presented to the IVF clinic were 40 years old and greater, right? And these are the women who want to conceive, but they have, of course, low ovarian reserve, and they now face a problem. The problem is, though, that at this age group, even IVF can't turn back the hands of time. So there is a real problem. When we look at the pregnancy rates per cycle, per age group, we see that women who are under 30 years of age, their chance of having a baby with an IVF cycle is about 43%. When we look at their 40 and over counterparts, when you're approaching 44, the chance of a baby is 2%, even with IVF. And you can see that even if you do, I don't know why this thing is so sensitive. Even if you do more than one cycle, it doesn't go beyond 5% with the third cycle. So social freezing empowers women to pursue personal goals without compromising future family dreams. Its popularity is increasing even in countries in Jamaica, as these services are now available in public as well as private centers. The advancements in technology, especially with vitrification of eggs, we now see that success rates are comparable. Frozen eggs are comparable with fresh eggs, and eggs so far can be frozen indefinitely. Medical freezing is also increasing in popularity, and this is due to the increased rates of diagnosing conditions such as endometriosis, which has shown to deplete ovarian reserve. So I have patients who are showing up early 30s with a poor ovarian reserve. We do an anti-Müllerian hormone level, and it's extremely low because endometriosis has now destroyed their ovaries, and they don't have any viable eggs, even for use for IVF. Medical egg freezing is increasing in popularity because of the improved in childhood and adult cancer treatments have improved so much so that patients are surviving more, and it's enabling them to live longer and aspire to build a family, even in patients who have had a previous cancer diagnosis. So what are the steps that one should take if one wants to embark on egg freezing? So the first step is to meet with your fertility provider. You will undergo tests such as I had mentioned before, your anti-Müllerian hormone level. You'll hear me speak a lot about this because this is a very important test. I think all young women should embark on taking an AMH level, even if they don't plan to have any children. It's just good to know. Other hormonal testing, such as doing your prolactin levels and your thyroid hormone levels, and of course, viral testing. Every time we're going to put a specimen in the, and we're going to freeze a sample because it's put together in the same container, we have to do viral testing for everybody. And some other adjuvant testing, such as knowing your sickle cell status, your blood group, and your HbA1c to make sure you're not diabetic. Another important screening modality is to do an antral follicular count, and this is done via an ultrasound where we look at the ovaries and we see those little black circles. Those are antral follicles which contain eggs. And we can't see eggs because they're microscopic, but we can monitor the antral follicle and we can monitor the development of the antral follicle, and it is in tandem with the development of the egg. So these are some basic investigations that need to be done before one embarks on egg freezing. The other step is to make sure that one learns about what the egg freezing process is about. They may learn that they may have to do more than one cycle to produce a cohort, which will increase their success. They should learn about the cost because it can be a very costly venture. And they should also have a psychological evaluation to make sure that they're mentally prepared to deal with it. Now, there is no guarantee that freezing your eggs you will end up with a successful pregnancy. So it's just fertility insurance, but it's not a guarantee that it will work. Now, the cycle preparation may involve taking a birth control pill so that we can time when you're going to have a bleed. We need to, get your medications ordered, confirm that you've completed all your pre-cycle testing and evaluations. We have to teach you how to give yourself the injections because yes, it's done for about 12 days. So you're not going to be coming into the center to do your investigations. And of course, they would have to sign consent forms, answer questions, and we'll schedule treatment. Now, part of the most important part of the treatment as it relates to egg freezing involves ovarian stimulation, right? Every month in a natural cycle, you only recruit 1 egg, sometimes 2. But when we're doing an egg freeze cycle, we want a cohort, as I had mentioned before, at least 15 eggs. And so we have to use a controlled ovarian stimulation. We have to force the body now by giving you excess follicular stimulating hormone to force the ovary to push out all of those follicles for that month. Now, it doesn't deplete your total egg count because it only pushes out the amount of eggs that you would have pushed out for that month. All right. So basically what we're doing is we're manipulating the APO axis, and we are now giving you exogenous FSH to force the ovaries to produce eggs. These are some of the medications that are used that contain FSH. We have Menopur, which is really human menopausal. So it's extracted from the urine of menopausal women. It contains FSH as well as LH, follicular stimulating hormone, as well as luteinizing hormone. And then it is also developed in the lab, and there's also a recombinant FSH, which is called Recovel. There are many, many different types of FSH that are on the market. Now, what happens in an ovarian stimulation cycle? The most common ovarian stimulation cycle is a short antagonist protocol. So what happens is that we start the medication on day 2 of the cycle, as you can see in this diagram here. You're taking your injections every single day as of day 2. Around day 6, you would come into the clinic. You would have ultrasound monitoring and a blood test to check your estrogen levels to see how many follicles have been recruited. So we look at your ovaries, we measure the follicles, and that tells us the size of the follicle tells us how well the follicles are developing. Now, around day 7 of the cycle, so this is what an ovary looks like. You can see that the follicles are much bigger than the other ultrasound picture that I had shown you. And this is an ovary that has undergone ovarian stimulation. So they increase in size, about 2 millimeters per day, they increase in size. Remember, these contain the eggs. All right. So as you can see in this diagram, and as of day 7, they will start getting another injection at the bottom, which is called the antagonist injections. And these are given to prevent premature ovulation. It basically shuts down the pituitary and prevents it from releasing LH, which will give you that surge for the eggs to be released from the follicles. Remember, we don't want this to occur because we want to be able to aspirate the follicle and remove the egg from the follicle. So the GnRH antagonists are given once a lead follicle, because follicles develop at different times, when the lead follicle is 14 millimeters or over. Now, we continue to monitor them by doing ultrasounds. And once you have a cohort of follicles, which are about 18 millimeters, the patient is given a trigger shot. And this trigger shot is in the form of human chorionic gonadotropin. We give them about 10,000 units, or we can give them recombinant HCG, which is 25 micrograms, and this leads to the final egg maturation. And what it does is that it causes the cumulus cells around the egg to become fluffy, and they separate from the follicle, making it easier for these eggs to be aspirated at the time of egg retrieval. In patients who have a lot of follicles or who have polycystic ovarian syndrome, we tend to want to give them a different type of trigger shots. So we give them the GnRH agonist, and this helps to prevent them from becoming very sick at the time of the treatment cycle. All right. So once the trigger shot has been given, exactly 36 hours later, they will present to the clinic for what is called the egg collection. So what happens at the time of egg collection? So they come to the unit, they are admitted for the day. We test to see if they have really taken their HCG, because this is one of the most important steps in the process. If a patient forgets to take her HCG or takes it at the wrong time, we will not get not one egg. So we do a test, especially if they've gotten HCG. We do a test, we do a urine test to make sure that it's faintly positive, and this assures us that she has taken it at the appropriate time. If it is very positive, it means that she's taken it too late. If it is negative, it means she's not taken it at all. We normally offer patients conscious sedation because it is a pretty painful procedure. We are using, under ultrasound guidance, we're using a 17 gauge needle. We're putting it through the posterior fornix, so the vagina, and we are now under ultrasound guidance, so we can see we're putting the needle. We put it straight into the ovary, and we're aspirating each follicle one at a time. This usually takes about 20 minutes. Of course, the length of time depends on how many follicles the patient has. So we have patients who have up to 30 and 40 follicles, and it takes a little bit longer. Of course, these patients will be more susceptible to hyperstimulation syndrome or getting sick after being stimulated. We normally give them IV hydration after the procedure, and then we discharge them and we update them in less than 24 hours. And this is typically what an egg retrieval room looks like. We see we have there's a window that connects to the lab. We have an aspiration machine, which is what we use to create negative pressure to basically aspirate the eggs out of the follicles. We have an anesthetist that comes in and gives the patient sedation so that they're comfortable. Once we have aspirated all of the eggs, they're handed over to the lab immediately and they're evaluated. They normally sit for about an hour before they strip the eggs and determine whether these eggs are mature or immature. Only mature eggs will be frozen because only mature eggs can be fertilized via insemination with the sperm. After the eggs are collected, of course, maturity is determined, then they will be frozen at negative 196 degrees Celsius, and they will be placed in liquid nitrogen storage tanks, and they can sit there until kingdom comes for further use. All right, so I have a question. What is the success rate of egg freezing in terms of live births after thawing? Is it A, 100%, B, 70%, C, depends on various factors, including the age at freezing and number of eggs, and D, less than 10%? Okay. We had touched on this a little bit when we spoke about what is the ideal, don't know. All right. Right, so correct. Most of the persons who responded said 80%, which is correct. It depends on various factors, which I'd spoken to about before. The ideal age is less than 35 years of age, and the number of eggs, you really want to have 15 or more to improve the success rate, because these eggs have to now be thawed, they have to be fertilized, they have to be left in culture, and they have to make it to the blastocyst stage before they are, the patient is given a transfer for implantation. All right, so I will touch on a little bit now about surrogacy and surrogacy in Jamaica. So ART is assisted reproductive technology, and surrogacy is another form of ART where a woman carries a fetus for another person. There are two general types of surrogacy. One is a traditional surrogacy, and how I remember this is that tradition means that it's from back in the day when ART didn't even exist. And so what happens is that in traditional surrogacy, the surrogate shares the genetic material of the child. And nowadays what we use is artificial insemination, where we produce a sperm sample and we inseminate it, we place it in the uterus of the surrogate. And so therefore the child is related to the surrogate, and we use the intended father's sperm, making the surrogate the genetic parent along with the intended father. Not so ideal. And this is why we have moved more towards gestational surrogacy, where you have to rely on ART because the intended parents will produce the embryo, and the embryo will come from either donated oocyte or donated sperm, and this is transferred to the uterus of the surrogate. It's a much cleaner process, and you find that there is not a lot of attachment to the child by the surrogate. Surrogacy may be divided into commercial or altruistic. And in the commercial surrogacy, the surrogate will receive monetary compensation. And this is done, in some countries in the world. And there's also altruistic, where she doesn't receive payment per se, but she receives compensation for pregnancy-related expenses, for her medical expenses, just for her time. Sometimes she has to stop working, so she will receive compensation, but it's not a payment per se. And this is known as altruistic surrogacy. All right, so very quickly, how is a surrogate selected? A surrogate should be a young person who is healthy, physically, mentally, and socially. We do test to make sure that the surrogate is physically healthy. And also we do a psychological evaluation to make sure that she has mental health. Her mental health status is adequate, and her social situation as well should be conducive to surrogacy. She should have a normal BMI. She should have previously carried a child to term and should have had a normal delivery. She should have a normal hormonal as well as a viral screen, which includes things like hepatitis, HIV, and VDRL. The intended parents commonly who use surrogacy are same-sex couples. We have a lot of male couples who come in requiring a surrogate. What they normally do is they normally get a donor, someone to donate eggs. They fertilize it with their sperm, and then they ask a surrogate to carry the pregnancy for them. It also exists in some heterosexual couples, and commonly it's in persons who the female has been hysterectomized, meaning she has her ovaries still where she can produce eggs, but for whatever reason, it could be because of previous childbirth and severe bleeding, she has lost her uterus, or her uterus is in such a state that it cannot carry a pregnancy. And so therefore they need a surrogate to house the embryo for them. It is also common in single men who don't have a partner. So they too also use donor eggs and ask a surrogate to carry the pregnancy. And it is also used by single women. So what is the process of gestational surrogacy? And this is something that I'll speak about gestational surrogacy because that is the one in which we routinely use embarking at our clinic. We tend to shy away from traditional surrogacy because of all of the emotional and social issues and legal issues that can come about with traditional surrogacy. So the process of gestational surrogacy involves selection of the surrogate, which is the most crucial part of the whole process. It's selecting an ideal surrogate for that person. We introduce the surrogate to the intended parent, and they can determine what form of relationship they want to embark in throughout the pregnancy. We have relationships that range from the surrogate meeting the person by a phone, but never ever meeting the person in face to face. We have relationships where the surrogate and the intended parent have a very tight relationship, and they continue this relationship after the birth of the child. The legal agreement is very important. They need to sign a legal document, and this should be discussed with them via 2 separate lawyers, and they sign the same agreement. Once this agreement has been signed and is produced to the fertility clinic, then the medical process of preparing the surrogate's uterus from implantation can be started, and the surrogate will undergo an embryo transfer. Now, surrogacy is a very complex form of assisted reproductive technology, and it requires an interdisciplinary approach. So we need to have the counselor involved, we need to have the lawyers involved, sometimes we have a nurse who is involved, who is actually acting as the in-between between the 2 parties. It is sorted by ethical, social, and religious issues. There are negative views which are associated with surrogacy, and most of it involves the notion that the surrogate is being taken advantage of for monetary compensation. So there's a lot of negative views surrounding this issue. But there are also positive views where it allows somebody who would have never been able to have a child, it allows them the opportunity to build an entire family with the use of a surrogate. It provides an avenue for procreative liberty for some women. It has proven, and I've seen it many times, to be a blessing and a medical marvel for many couples to date. So the question I wanted to bring regarding surrogacy is, what is a significant difference between traditional and gestational surrogacy? Traditional surrogacy involves using the surrogate's eggs, while gestational surrogacy does not. Gestational surrogacy is more common than traditional surrogacy. Traditional surrogacy involves the surrogate carrying the child, while the gestational surrogate doesn't, and there's no difference between the 2. Okay, so, right, so the majority of the majority got it correct. Traditional surrogacy involves using the surrogate's eggs, while gestational surrogacy does not. Okay, we're moving on. Okay, surrogacy in Jamaica. I've had a lot of persons who have said surrogacy is not legal in Jamaica, it's illegal. It's not illegal in Jamaica, it's just that our legal system has not recognized surrogacy and doesn't speak to surrogacy, and it hasn't recognized assisted reproductive technology. So there's no recognition that somebody can produce an embryo outside of the body and actually put it into someone else's body. I think that is the issue here. So what happens is that when a surrogate gives birth, the birthing person is recognized as a mother in our legal system. And so that is a problem that exists with surrogacy in Jamaica as it is. So no matter how much the fertility center has documented evidence that the genetic material belongs to the intended parent, once a surrogate or a person delivers a child, that is the mother of the child, and that's what goes down on the paperwork, on the legal paperwork. So what happens now is that in Jamaica, the intended parent has to undergo now a lengthy process of adopting the child. So the intended father's name can go on the birth certificate,
but not the intended mother's name. And so the intended mother now has to adopt her own child. All right. So this is a very challenging situation. Not only that, but the surrogate now has to attend court to relinquish custody of the child, which is another, pet peeve. So even though a legal contract has been formulated between the two, and it does carry weight, this only exists for circumstances where there is now a disagreement between the surrogate and the intended parent, if they have to go to court. All right. So hopefully we can, some headway can be made to address our legal system so that ART can be recognized as something that, happens in Jamaica, so that we can know a surrogate doesn't have to go to court to relinquish her rights. We can now just produce the fertility documents, which can speak to the fact that the intended parent is really the parent of this child. Okay, studies, and there's a lot of skepticism about surrogacy in Jamaica, but studies have convincingly shown that children through the third-party reproduction are doing well psychologically and developmentally, and do not appear to be adversely affected by the lack of a gestational link to the intended parent. I think that concludes the presentation.
Thank you so much. All right, Doc, so we have some questions here for you. But first, I'd like you to, well, you're not saying no, but the ones are going up in the chat. So everybody's appreciative of the presentation. So Livingston asks.
Oh,
okay. It's like ASL. It's like, yeah.
Okay.
At what age should a couple give up on conception?
Okay, well, I know a lot of people will have my neck for this, but I don't think there's any cutoff age, because ART is such a, there's so many avenues as it relates to assisted reproductive technology. I'd give an example. Fairly recently, I had a 56-year-old woman who's never had a child before. She wanted to be able to have a child. Of course, at the age of 56, she would not be able to produce any eggs. So we got a donor for her. At the age of 56, we kind of shy away from persons getting pregnant because of chronic diseases, etc. So what we did is we said, okay, well, use a surrogate. So she got donor eggs, fertilized it with sperm, and the babies, it ended up being twins, were carried by a surrogate. And she's now very happy raising her children. And what she said to me the other day was, I love them so much, I can't imagine if I had carried them or if it was my eggs, loving them any more than I do now. So I don't know if that answers the question, but I mean, you can mother children or father children at basically any age with the advent of assisted reproductive technology.
Thank you so much. Dr. Frederick, does it mean that diabetics can't freeze their eggs?
Diabetics can freeze their eggs, but they should be properly controlled to undergo the procedure of egg freezing. So that's why we do it as part of the preliminary investigations, to find out if they're diabetic so that we can treat them and have them properly controlled.
Okay, thank you. Question here says, which is more likely to lead to a viable pregnancy? Thawed eggs plus sperm or thawed embryo?
Okay. I don't understand that question, but just to say that nowadays, with the advent of vitrification of eggs, freezing eggs are found to be just as successful as using frozen eggs. Frozen eggs are just as healthy as fresh eggs. So if we have frozen eggs, we thaw them, we fertilize them, as opposed to having fresh eggs which are fertilized, they basically do perform on the same level in terms of a successful pregnancy.
Thank you so much. A couple is considered to be having fertility issues after 1 year or 6 months, depending on the age. Is this the case even when coming off longer term contraceptives?
Okay, so
when you are, so if you are using something like a Depo-Provera, you may have to wait a little bit longer because the body may take a little bit more time to start ovulating again. So it depends on, so yes, if you're using a long-term contraceptive such as a Depo-Provera, which can lay around in the body for a little while, you may have to try for a little bit longer to say that you are not able to conceive naturally.
Thank you so much. What if the surrogate mom changes her mind and wants the child due to attachment? I'm assuming that's in the case of
The
using
gestationals,
someone's
right. So that's one of the reasons why we kind of shy away from traditional surrogacy. So that sort of situation is more likely to happen in a traditional surrogacy process where the surrogate is related genetically to the child. And that has happened before. In gestational surrogacy, especially in Jamaica, I find that once we go through the right protocols in terms of thoroughly evaluating the surrogate, it tends to be not as common, but it can happen. And everybody is aware that that can happen. But of course, the legal paperwork is supposed to help to protect the intended parents. Now, it also, how you go about the surrogacy process is also important. So things like asking the surrogate to buy baby clothes, asking the surrogate to breastfeed, those sort of things can lead to a sort of maternal bonding, which are discouraged in the process. So you have to be prepared as the intended parent, and you have to know what are some of the do's and don'ts in terms of carrying out a successful process.
Thank you so much. In Jamaica, and there are a lot of questions. In Jamaica, do persons do surrogacy as a career?
Well, what we practice in Jamaica is altruistic surrogacy. So yes, they do get compensated, but it's really for their time, and if it's not really a payment as it is now. So I wouldn't say that it's enough funds to be able to last you for your lifetime. We do have surrogates that that practice surrogacy more than once. So they do it maybe 2-3 times. I don't usually encourage it more than 3 times. But I wouldn't say you can make a career out of surrogacy, or you should think to make a career out of it. I believe that surrogacy should be more of an altruistic experience where and that's sometimes when I speak to surrogates, that's one of the red flags that I look for. If a surrogate is talking about money and she wants to quit her job, and I kind of discourage that sort of thing.
Thank you so much. Re-egg freezing. What is the cost to do so in Jamaica?
Okay, so the cost is about, and we usually quote these prices in US, it's usually about $10,000 to freeze your eggs.
Thank you. And there's a question here. Can a person be a surrogate if they've never had a child before?
I guess they can, but at our center, we don't practice that. A surrogate should be somebody who has proven to be able to carry a child successfully to term. It's very iffy and butty to ask someone who's nulliparous, who's never carried a child before, to be a surrogate, because you don't know what to expect.
Thank you so much. Would you recommend egg freezing for women with fibroids?
I recommend egg freezing for all young women.
Oh, wow. This question, what about sperm preservation? Is that something that could be done? And at what age should it be considered, if at all?
Well, yes, we do sperm preservation, and it's usually done for medical reasons. We have men who come in who have prostate cancer, testicular cancer, and they want to preserve their sperm. It's something that we do, and it is highly encouraged. Now, sperm preservation for social reasons, not as common, because of course, men generate sperm unless they have a condition that, or they have a decline in sperm count. That would be the only indication for sperm preservation.
Thank you so much. How does a same-sex couple access surrogacy services in Jamaica, especially concerning the legality of same-sex relationships in Jamaica?
Well, they don't have to necessarily come as a couple. They can come as an individual. Okay, because remember that we don't need a couple to undergo the process. So a man can come as just a male. He can access donors' eggs. He uses a surrogate. So we don't really deal with the couple per se.
Thank you. Final question. Do you freeze embryos?
Yes, we freeze embryos all the time. So we do IVF. When a person does an IVF cycle, a lot of times they have excess embryos. And so we have to freeze them for later use.
Everybody, please give Doc a round of applause. Thank you so much.
Dr. Fredericks, on behalf of the Aventa Jamaica team, I just want to thank you for a very educating presentation on social freezing and surrogacy. I think we've all learned a little more in terms of process. So thank you very much.
You're most welcome. Thank you for having me. Okay.
And just take that mic off.
Oh.
All right, everybody, thanks for staying with us. So just as a little bit of housekeeping while we do some things here in the background, CE credits will be 4 CE credits. And of course, you will do your quizzes, and those persons who choose to do all 4 and pass all 4, you'll qualify for 4 CEs. So next we're going to go into a sponsor presentation by Ferring.
Good morning, everyone, and thank you so much for being here for this CE. Ferring is very excited to be associated with this CE, following especially Dr. Frederick's talk. Next slide. So I always like to start my presentation by telling a little bit about Ferring. Ferring, for many people, they think it's a new company. Actually, we're not. We were founded in Sweden in 1950. So we're actually celebrating our 75th birthday. So we're older than you, Aventa, I think. So I'd like to see some applause in the chat. In the chat, I want to see the applause for 75th birthday this year. So we were founded in Sweden in 1950. And we're currently headquartered in Switzerland. Our mission at a glance is to help people build and live better lives. But one of our most overarching missions is to be the world-leading, most trusted healthcare company in reproductive medicine and women's health. I would say 6 areas that we focus on: reproductive medicine, which we divide into our fertility portfolio as well as our obstetrics portfolio, gastroenterology, urology, orthopedics, and endocrinology. For today's presentation, I'll really focus on our work in reproductive medicine and women's health. Our mission is to pioneer a new era in fertility where all potential parents are empowered to build families. So we believe that we are the company that, as a matter of fact, we define ourselves as the conception to birth company, because before you become pregnant, we're there to assist with assisted reproductive technology. We take you safely through pregnancy and even after birth, and you'll see that in our portfolio. So Dr. Frederick mentioned a couple of our products that are used in the process of ART, our Menopur and our Recavel for controlled ovarian stimulation. But we also have products to help with the triggering of the egg. We have products to the agonist, the gonapeptyl daily, to shut down the axis. We have products like endometrium. A lot of you on the call now know our endometrium, which is our progesterone, which is used during the first 3 months of the pregnancy for luteal support and to help with that attachment of the egg. So we have a wide range of products that take you safely through the IVF process. But then what happens once you get pregnant? We know that there are complications. We have things like preterm birth, and we have the only product indicated. Now, we may use nifedipine and other products to prevent or delay preterm birth, but the product that was manufactured for that is our atosiban or Tractosal. So we have products that delay preterm birth, which is a very common complication in pregnancy. Another very common complication is postpartum hemorrhaging or excessive bleeding after birth. And here we have our Duratocin or Pabal, and we're happy to say that it has been adopted by our Ministry of Health and is available now in all public hospitals. And this really happened because the Champion study proved that a room temperature stable product was just as effective as regular oxytocin. And of course, you all know our endometrium. So as I said, Ferring is committed to building families worldwide. We believe that everyone should access quality care and treatment to help them build families. So we want to be there in your fertility journey. We want to be there in your healthy pregnancy, hopefully taking you to term. And also we're there at the end of the pregnancy to ensure that we minimize excessive bleeding and postpartum hemorrhaging. We know, and Dr. Frederick spoke about it, all families are different and we care about them all the same. So one of the things that Mrs. O'Sullivan mentioned is the changing family dynamics. Families are not looking the same way they used to look. As the mother of a child, a Gen Zer, Gen Z is that the latest one, Gen Zer, who is telling me she doesn't want to have children. And she's saying that now because, of course, she's career focused and wants to pursue her career. I may have to kidnap her and take her down to Dr. Frederick's clinic and get those eggs because she is now my only hope of grandchildren. So we are here to support, and that's the mission of Ferring. One of the things that, I don't know if you mentioned it, Dr. Frederick, but 1 in 6 couples worldwide experience infertility. But as we said, Ferring is here to help. We have over 500,000 babies born every year, thanks to ART. And we're happy to be a part of that building of new lives together. And as I said, and this is a little disturbing because our numbers in Jamaica are not looking good. We had a spike in maternal mortality after COVID. So in 2020, the numbers in our maternal mortality numbers went up. The goal in terms of the Sustainable Development Goals is for every country to have 70 or less deaths per 100,000 births. And unfortunately for us, we are at 103, I think. So we have moved away or further away from the goal that was set for 2030. And we're just 5 years away from 2030. So Ferring is committed to reducing maternal mortality and morbidity. And with those efforts, we have collaborated with the WHO, with MSD for Mothers, to strengthen postpartum hemorrhaging prevention efforts, and especially in countries that there are issues in terms of maintaining the temperature of the products that are used. And again, back to our mission of preventing preterm birth, this is another very concerning thing. 15 million babies are born too soon. And so when we created Atosiban or Tractocil, it was with that mission to see how do we slow down or prevent preterm births and allow babies to at least get to term, or if not get to term, have that extra 48 hours where steroids can be administered, and so giving the baby a better chance of survival. We are a R&D focused company. We're a science-driven organization. We have a strong track record in peptide-based treatments. And as I said, our focus areas are fertility, obstetrics and gynae, gastroenterology, and urology. These are just some of our leadership principles. I won't spend too much time here, but I invite you to connect with us. We're on LinkedIn, we're on Twitter or X, Instagram, YouTube. Learn more about Ferring. We're here, and we're here in Jamaica to stay, and we're very happy to be here partnered with Aventa to bring our portfolio to this to Jamaica. So thank you very much. Let's hand over to Peter.
Back and I am so grateful. We need to give Karen a little round, some ones and some absolutely. So let me tell you now, I have Teddy in here and I have Tyrone in here and I know Rowan is online, and I'm saying, how could Jamaica ever have a birth rate situation going on? What is happening? Thank you very much. We've got to investigate this. There is no way Jamaica should have any birth rate decline. And we need to have some sort of a discussion. And ladies, we have to take it very serious. Now, I'm saying that when I was 25, that was 20 years ago, something like that, you know? Where was Dr. Fredericks at that time? So I could think about freezing something, you know, Karen, but it has happened, and I'm grateful that that provision is here. And I've learned some new words, you know, like ovarian reserve and fertility insurance. I am learning. I trust you are learning and you are being entertained. But I know Sam is managing me as I manage him. We're at that time, Sam, and I think we're running good in time. Thank you very much, sir. That we're going to have a mandatory coffee break, right, Sam? And it is right now 10:50. What time? How long will the coffee break be? We start back at 11:20. So don't go too far. Grab your coffee, grab something. We're going to certainly grab each other and eat something and talk about this birth rate thing. I've got to address it. And we'll be back at 11:20.
Our group's story begins in Trinidad and Tobago and has expanded across the region. Legacy companies with diverse cultures have evolved together, creating a unique and dynamic Caribbean force. Now, this is our moment. Our collective energy has sparked our transformation and will ignite the future of Agostini. The new Agostini identity respects our history while representing the group's dynamism, synergy, and strength. The four leaf-like shapes represent our employees, partners, customers, and communities, which all come together to create the spark that makes Agostini a powerhouse and engine of growth in the Caribbean and beyond.
The rebranding effort, even though it's on the surface in a sense, it doesn't change who we are and the people that we have there. I think it does materially allow our suppliers and other stakeholders to see us as a single entity rather than multiple entities across the region.
Ocado encapsulates all our consumer products and distribution operations. The name Ocado comes from our can-do attitude, which has allowed us to reach across the Caribbean with our products. Aventa is the name of our latest acquisition and is a new identity for our group's pharmaceutical and healthcare business. Aventa evokes the word advance, and working together to advance health while innovating is at the core of our identity.
I think the rebranding sort of brings together the best of both worlds. One is that as a group, we've always operated in a very sort of decentralized way, where management of the individual businesses have a significant amount of autonomy in how they operate those businesses. And I think that's worked really well for us over the years, and that's something that in this rebranding, we wouldn't want to lose.
In the future, we will all be bound by this common identity.
We are very strong in the Southern Caribbean. We own a lot of businesses that operate as number one in many of our markets. We continue to expand northbound, and this is very exciting for us in terms of where our future is.
More recently, the pharmaceutical group has gone through a period of acquisition, so entities in Barbados, Jamaica, Curacao, and Aruba. So now the pharmaceutical group is going through that phase of coming together as a group of companies around the region.
We have grown over the years in getting different products. Now that Agostini group of company have us in their hands, then we realize that even the products have been growing. We now acquire the line Decas, we acquire the Carile line, which we are the sole distributor for in Jamaica. And it's coming on, people is really gravitating towards it, and it's a good feeling.
I think the evolution of Agostini's really is something to be very proud about. This is what was a family company once upon a time that has now become a major player in the health ecosystem, not only in Trinidad, but now expanding regionally. Over the last 2 years, we've had a lot of focus on moving just beyond Smith Robertson, but now, how can we now serve the wider community in the Caribbean?
The resilience, ambition, diversity, and vision of our people have enabled our group to thrive.
First one is always be the people. People, right? So without people, this company won't move, it won't train, it won't deliver. People come every day and they bring it. They bring their performance, they hit their targets year on year. Seeing on Agostini's, we hitting our targets every single year.
Your future looks quite bright with a wider customer base, a stronger brand recognition, and more growth opportunities.
The advantage of this company growing is that other opportunities are going to be created, and that is especially for persons who are career-driven. I can see that it's good when you see in Trinidad, you see in Antigua, you see in all these different mirrors of Caribbean countries coming together. Growth, that's the only thing I can see.
We want to continue to build and enhance that team that has been able to take us across the Caribbean and to be able to take us beyond the Caribbean.
Our story continues, with our group leading as a benchmark for innovation, empowerment, and success in the Caribbean region and beyond.
It is an exciting time. I think from a business perspective, the opportunities that this brings to us as a company, to all our stakeholders, there would be significant opportunities to innovate, to grow, to develop as an entity. And I feel with the rebranding taking place, it just opened doors for us, and the sky's the limit.
This is the future of Agostini. Our group's story begins in Trinidad and Tobago and has expanded across the region. Legacy companies with diverse cultures have evolved together, creating a unique and dynamic Caribbean force. Now, this is our moment. Our collective energy has sparked our transformation and will ignite the future of Agostini. The new Agostini identity respects our history while representing the group's dynamism, synergy, and strength. The 4 leaf-like shapes represent our employees, partners, customers, and communities, which all come together to create the spark that makes Agostini a powerhouse and engine of growth in the Caribbean and beyond.
The rebranding effort, even though it's on the surface in a sense, it doesn't change who we are and the people that we have there. I think it does materially allow our suppliers and other stakeholders to see us as a single entity rather than, multiple entities across the region.
Ocado encapsulates all our consumer products and distribution operations. The name Ocado comes from our can-do attitude, which has allowed us to reach across the Caribbean with our products. Aventa is the name of our latest acquisition and is a new identity for our group's pharmaceutical and healthcare business. Aventa evokes the word advance, and working together to advance health while innovating is at the core of our identity.
I think the rebranding sort of brings together the best of both worlds. One is that as a group, we've always operated in a very sort of decentralized way, where management of the individual businesses have a significant amount of autonomy in how they operate those businesses. And I think that's worked really well for us over the years, and that's something that in this rebranding, we wouldn't want to lose.
In the future, we will all be bound by this common identity.
We are very strong in the Southern Caribbean. We own a lot of businesses that operate as number one in many of our markets. We continue to expand northbound, and this is very exciting for us in terms of where our future is.
More recently, the pharmaceutical group has gone through a period of acquisition, so in entities in Barbados, Jamaica, Curacao, and Aruba. So now the pharmaceutical group is going through that phase of coming together as a group of companies around the region.
We have grown over the years in getting different products. Now that Agostini group of company have us in their hands, then we realize that even the products have been growing. We now acquire the line Decas, we acquire the Carile line, which we are the sole distributor for in Jamaica. And it's coming on, people is really gravitating towards it, and it's a good feeling.
I think the evolution of Agostini's really is something to be very proud about. This is what was a family company once upon a time that has now become a major player in the health ecosystem, not only in Trinidad, but now expanding regionally. Over the last 2 years, we've had a lot of focus on moving just beyond Smith Robertson, but now, how can we now serve the wider community in the Caribbean?
The resilience, ambition, diversity, and vision of our people have enabled our group to thrive.
First one is always be the people. People, right? So without people, this company won't move, it won't train, it won't deliver. People come every day and they bring it. They bring their performance, they hit their targets year on year. Seeing on Agostini's, we hitting our targets every single year.
Your future looks quite bright with a wider customer base, a stronger brand recognition, and more growth opportunities.
The advantage of this company growing is that other opportunities are going to be created, and that is especially for persons who are career driven. I can see that it's good when you see in Trinidad, you see in Antigua, you see all these different mirrors of Caribbean countries coming together. Growth, that's the only thing I can see.
We want to continue to build and enhance that team that has been able to take us across the Caribbean and to be able to take us beyond the Caribbean.
Our story continues, with our group leading as a benchmark for innovation, empowerment, and success in the Caribbean region and beyond.
It is an exciting time. I think from a business perspective, the opportunities that this brings to us as a company, to all our stakeholders, there would be significant opportunities to innovate, to grow, to develop as an entity. And I feel with the rebranding taking place, it just opened doors for us, and the sky's the limit.
This is the future of Agostini. Our group's story begins in Trinidad and Tobago and has expanded across the region. Our group's story begins in Trinidad and Tobago.
Hi, my name is Glenys Durant-Freckleton, the CEO for Aventa Jamaica Limited. We're here today for our town hall. It's all about rebranding. We were formerly Health Brands Limited and we are now renamed to Aventa Jamaica Limited. This renaming is a regional initiative. We're a part of the Agostini Group and all of our pharmaceutical companies are now going to be called Aventa. So we're very excited. We have persons from the group joining us today, and it's going to be very exciting when we talk about Aventa and all that it means for the team. So we're very excited and looking forward to you seeing it in our space. And this is Aventa Jamaica Limited.
As you guys know, Carnival is not over, but I need some serious post-Carnival care, so let's go. Now, in true Ari fashion, I got sick after Carnival, and thanks to my natural team, I have everything to help nurse me back to health. Now, the first thing that was really important to me was hydration, because I was on the road all day Sunday and sounded hot. And with the flu, I've been feeling very lethargic, so having this B-complex vitamin has been a huge lifesaver. And of course, as a true minister of enjoyment, I was getting on in the dance. So it was no surprise to me when I woke up the following day and my knees were hurting me. The doll though young like one time and she's starting to realize, but this Go Gel really helped. Trust me, we got my natural team because this bag really came in handy.
Hello, my name is Pilar Hernandez. I work for ASO Pharma and we have been working with Aventa for many years. As a company, they are our distributor, and we are glad to be part of this new era of Aventa, representing not only here in Jamaica, in the rest of the Caribbean countries. So for sure, we know that it will be a really good experience for all of us as suppliers, as partners, and the most important part is to make a difference in our patients' life. Thank you.
Hi guys, so as you know, I received an amazing package from Aventa. I'll tell you about the few that I do really love.
The B-complex.
It's a combination of B vitamins that's used to treat iron deficiencies for a number of reasons, whether it's based off diet, whether it's based off critical illness, or for persons who might just be pregnant, like myself. It raises the energy levels of your body and it helps to fight fatigue, laziness, and tiredness, especially if it is that you have long days, if it is that you exercise a lot like myself, and sometimes you need that extra, pick me up. This is your goal. It helps with the production of collagen, which is a protein that's essential for your hair, your skin, and your nails, so you cannot go wrong. Don't forget, it can also boost your mood and reduce symptoms of depression and anxiety. So be sure to check it out at your local pharmacies or doctor's offices.
Deworm effectively. Albendazole is an anti-worm medication. It prevents newly hatched insect larvae or worms from growing or multiplying in your body. Wormazole has delicious strawberry flavor and is best taken with food, not to be given to children under age 2 unless prescribed by a doctor, and is recommended for the whole family to be taken twice a year and is very affordable. Vitamex, nutritious, delicious for all, the most complete multivitamin and mineral syrup on the market. Deliciously nutritious pineapple flavored syrup fortified with L-lysine, an essential amino acid which acts as an appetite enhancer. Great for diabetics as it is sweetened with sorbitol, which is a sugar substitute. Vitamex is great for vitamin supplementation during pregnancy, lactation, convalescence, ill health, and appetite and calcium deficiency. Vitamex has vitamin A for strong bones, teeth, and immune system. Vitamin B helps with the nervous system, brain, muscles, heart, and blood cells. Vitamin C protects the immune system, prenatal health problems, and eye disease. Calcium, good for bone health, protects against cancer, high blood pressure, and diabetes. Iron helps fight fatigue, plays a vital role in immune system function, treating anemia, boosting hemoglobin, and much more. Vitamex is to be taken orally. Go Gel keeps you going. Fast relief of joint, muscle, lower back, and arthritis pain. All the ingredients work together to reduce pain. Diclofenac diethylamine reduces pain, swelling, and inflammation. Menthol salicylate for temporary relief of muscle or joint pain caused by strains, sprains, arthritis, bruising, or backaches. Capsaicin helps to relieve pain. Linseed oil reduces inflammation. Menthol provides a cooling sensation when applied to the skin. Godel keeps you going. Easy Step Pregnancy Test. Accurate, easy, early detection. You can test as early as 4 days before expected period. Easy to use midstream stick, no cup, just stream on stick. With increased sensitivity to the pregnancy hormone means greater ability to detect pregnancy earlier. 2 lines means positive, 1 line is negative. Results in 3 minutes. Easy Step Pregnancy Test. Rapid, accurate, and easy results. Total All Natural Skin Repair Cream. Calms minor skin inflammation by reducing the swelling, redness, and heat associated with minor skin wounds. Fights minor skin infections by allowing wounds to heal quicker, and moisturizes while healing wounds. Indicated for cuts and scratches, nappy rashes, insect bites, blisters, and minor burns, dry and cracked skin, and sunburn. Natural healing skincare. Total. Stay hydrated with glucolite. Glucolite is a rehydration salt which is used to replace salts and water that the body loses when you are dehydrated. Certain types of salts, sodium, chloride, potassium, are needed by your body for many processes. Example, to regulate water in and around the cells, for brain function, to aid digestion, and to regulate blood pressure. So it's important to replace them if you've become dehydrated. Oral rehydration salts, or ORS, are a mixture of electrolytes, salts, and carbohydrates in the form of sugar dissolved in water. They are used to replace salts and water that the body loses when you have dehydration caused by gastroenteritis, diarrhea, or vomiting. Unlike other fluids you might drink to replace what you have lost, the proportion of salts and sugar in an ORS matches what your body needs to recover. Glucolite can be made by boiling water, let it cool, dissolve contents of sachet to 1 liter of water. Infants and children under 12, max 1 to 2 liters over a period of 24 hours. Adults, max 2 to 4 liters over a period of 24 hours. Discard any unused portion after 24 hours. Glucolite. Stay hydrated. Naturella 5-in-1 Cream is an intensive moisturizer promoting a healthy, blemish-free, radiant complexion while providing full-spectrum UVA, UVB protection. This is a blend of ingredients such as licorice, which lightens dark spots and keeps your skin elastic and healthy. Toned skin, repairs uneven skin tone, protects skin from sun damage, improves skin texture and elasticity for younger looking skin, can be applied under makeup. Provides all day hydration for the skin. Naturella, be flawless.
Change can be kind of scary. Change can even be fun. And nowadays when you buy things at the supermarket, you're not getting a change because money done. Change can mean elevation. Change can bring something brand new. But sometimes when things change, and not everything, are just a few. Humans change all the time. Them change behavior, them change them shot, them change all them diet, and start that gym, because them try control them gut. But not just humans alone. You know, say companies change too. And today, we have the honor to announce one of these changes to you. So I partner with Aventa Jamaica. Them better give me some things to showcase. You know, so them used to name health brands, and it used to name Medigrace. Them all about innovating together. You know, health is wealth, and we have to keep strong. And them make Dika, B-complex, Histal. Yeah man, them about long. So you know what people you can trust, enhancing lives years by years. And yes, they make changes, but guess what? I shift gears. Anyways, that's all for today. Thanks to stop by and watch this post. But before me let me have a question. Which Aventa products you use the most? Story rhymes.
To prepare for an upcoming colonoscopy, patients need to be provided with an effective and well-tolerated, but also easy-to-take bowel cleansing product that can help to improve their compliance. Pika Prep is an oral bowel cleanser with a powerful dual mode of action. It fulfills these requirements, allowing optimal visualization for the physician during colonoscopy. Pika Prep contains 3 molecules: sodium picosulfate, citric acid, and magnesium oxide. In water, citric acid and magnesium oxide form a magnesium citrate complex. Magnesium citrate and sodium picosulfate are responsible for the dual-acting bowel cleansing effect. Once Pika Prep is ingested, the free magnesium ions that are dissociated from the citrate complex cannot be absorbed easily by the intestinal wall. The resulting concentration gradient leads to a strong osmotic effect. Water is drawn into the lumen of the colon. The loss of liquid from the tissue is compensated for by the amount of additional fluids patients are advised to drink when taking Pika Prep. In this way, the stool is softened and can easily be washed out. The second substance, sodium picosulfate, is converted by bacteria in the colon into an active metabolite. This then stimulates nerve endings in the intestinal wall, thereby increasing peristalsis. The contractions carry the bowel content along towards the sphincter. Pika Prep's dual mode of action softens the stool and stimulates peristalsis, cleansing the colon of fecal matter, and in this way facilitating a smooth examination and a clear visualization of the colon. Pika Prep, an effective, well-tolerated and easy-to-take bowel cleanser. Pika Prep is taken orally, has an orange flavor, and cleanses your colon. Clinical trials have demonstrated that it is well tolerated by patients. However, should you experience any problems during treatment, or if you have any further questions, please consult your physician. Pika Prep Bowel Cleanser by Ferring.
Shake it to the max. The DJ turn up the bass to the max. Please just rewind, let me shake it to the max. 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 Please just rewind, let me shake it to the max.
Aventa, Jamaica.
Aventa, Jamaica.
Aventa, Jamaica. Aventa, Jamaica.
Aventa Jamaica.
Aventa, Jamaica.
Aventa Jamaica.
Aventa, Jamaica.
And have you ever heard the name Aventa, formerly known as Health Brands Limited? Aventa Jamaica was established in 1975, and over these past 50 years it has established itself as a very trusted name in Jamaica's pharmaceutical distribution sector. It began as a subsidiary of the Jamaican iconic group Grace Kennedy Limited. Aventa Jamaica has played a pivotal role in delivering quality healthcare products across Jamaica. In 2023, it was acquired by the Agostini Group, and now the company is well positioned to combine its local knowledge and expertise with the group's financial strength and regional distribution network to better serve you, its customers, its partners. And here to tell us more about Aventa Jamaica is the company's CEO, Glenys Durant Freckleton. Good morning.
Good morning, Cliff. Thank you for having me.
You're welcome.
I'm very excited to be here and Aventa Jamaica, just to know that we are a pharmaceutical distribution company. And we have been around since 1975, as I noted, 50 years, March, since this year we were 50 years old. And so we actually have been a staple in the Jamaican communities, distributing all across the island, and we do distribute pharmaceutical and personal care items. So we have principals such as Carile, Health 2000, Ferring, and DKs. And we do treat a number of conditions, not only for the personal care, but the diabetes, fertility, cancer, and we also have vitamins that we distribute as well.
Wow. So it's a very diverse range.
Very diverse, and we do have a very large customer base, including the government. So we also supply the government, the JADET program, as well as the National Health Fund.
And tell me, how has the company evolved over these past 50 years?
It's been a journey for the company, and I think that the company is poised for even better growth as a result. Started as a subdivision in Grace Kennedy, and was divested at the time in 2006, just because the Grace Kennedy at the time was focusing on their core business, but it really stood firm in pharmaceutical distribution and distributed as and operated as a private enterprise until 2023, where we were acquired by Agostini. And that actually is a regional company headquartered in Trinidad. But the good thing with Agostini is that one, it becomes 100 this year, which is a staple. It's been around for some time, but it provides us with a level of expertise that really has enhanced our operation. We've actually been growing since then, and we're looking to grow even further.
And where you see that growth taking place?
The growth will take place in our personal care and lines. Also, we see some opportunities for our ethicals, which is really around our main core pharmaceuticals, but those are the two main areas that we see potential for growth in.
And people...
Welcome back. When we ended, we had over 900, over 1,000 persons online. And so that was very good. We're back and it's 8:90. So we definitely know that some persons are yet to come back from the coffee break. And that's wonderful. I have the names. I have 4 more names of persons who will get gift baskets from the top 15, the first 15 registrants this morning. So Jogesh Edwards, Alison Mentor, John Sheppy Nicholson, and Sashana McDonald Salmon, all winners this morning. Joan, it's Joan. Thank you so much, Joan Sheppy Nicholson. Thank you so very much for that. But here's something else. We have a little time to give you another gift. We want to build a mnemonic out of Aventa. And what do I mean by that? A, I've started mine already. A is for advancing health. V is for value driven. E is for enterprising. So I need somebody or somebodies to begin to put together their Aventa mnemonic, submit it in the chat. We are going to look at it, and the persons whose mnemonic is chosen will get a gift from Aventa. So I need to see the ones go up, because when that person wins, the ones are gonna go up also. You don't see any ones coming, no, Sam? Whoa, I'm telling you, man. Shot where shot. All right, so we're gonna get right back into the stream of our presentations. At this time, it still is morning. Julian Robinson Gemot. I want to start by saying what better person to have today but Julian Gemot to provide the update on what's new in pharmacovigilance. Julie, I'm at liberty to call her that, is the scientific officer at the Ministry of Health and Wellness and a focal person for the National Pharmacovigilance Program. She has training in signal detection, causality assessment, and pharmacovigilance from Uppsala Monitoring Center. And Uppsala is in Sweden. She's also the focal point in substandard and falsified medicines. And she represents Jamaica in the WHO and PAHO Pharmacovigilance Network and SF program. Julie has made several presentations, both locally and internationally, regarding pharmacovigilance and has been involved in various workshops to pharmacists, pharmacy students, and other health professionals on post-market surveillance. Her professional associations include the CAP and the International Society of Pharmacovigilance and Regulatory Affairs Society. Today, our presenter for the topic Pharmacovigilance Update, What's New, Julie Gemma.
And my objectives for this morning are here listed for you to read. So you heard in my introduction that I do lots of workshops on post-market surveillance. And I can't start this presentation without bringing something to that. So what is it? It's a continuous monitoring of the safety, efficacy, and quality of the drugs after they have been placed on the market. Now, you know that when drugs come onto the market, they have gone through some rigorous trials to determine their safety and efficacy. For them to be on our market, the Ministry of Health has to go through all of these safety studies and also to look at the quality of these medications, because these products will eventually be what is going to be leading our public health systems. Now, post-market surveillance has two arms, where we look at the quality and where we look at the safety and efficacy. The quality really deals with the substandard and falsified medical products, whereas the safety and efficacy looks at adverse drug reactions, periodic benefit evaluation risk reports, or PBERs, what they're known as, and risk management plans. This is what is considered as pharmacovigilance. However, there are times when a quality issue leads to a safety or efficacy issue. And conversely, a safety or efficacy issue will lead to a quality issue. But our focus today is pharmacovigilance. And exactly what is that? When we look at pharmacovigilance, we're looking at scientific activities, data gathering activities relating to detection, assessment, understanding, and prevention of adverse drug reactions or other drug-related or DRPs. So, what is detection? This occurs when we recognize, record, and report that there is something going on with a particular individual and a suspected drug. We normally get these reports, which are also known as individual case safety reports or ICSRs, from our healthcare workers, including yourselves, our consumers, who can be the patients themselves, their caregivers, and our marketing authority holders. These reports then come into an assessment process where we look for a causality. Is the drug causing this problem? And it is at this stage where we move from suspected to an actual adverse drug reaction related to the product. From that assessment, we get a clear understanding on the who, what's, whys, wheres, and whens. This is important because we need to now put in measures that will either minimize the event from occurring or prevent it from occurring. And this is done at the national level. We do have our marketing authority holders who will do some of this activity as well as part of their routine safety precautionary pharmacovigilance activities. Some of these activities that can be done is the mandatory reporting of the PBERs by the marketing authority holders. So what are these reports? These reports involve giving us all of the reports they have received from various other countries with regards to their product. And they're going to look at these products and analyze them to say whether or not they still meet efficacy and safety standards. We have voluntary reporting, and I should have put voluntary here in quotation marks because it's not really voluntary, but we ask you to report as healthcare workers and even consumers of anything that you may be getting from your medication. You heard about us analyzing these case reports, and we also analyze, and the marketing authority analyzes these reports. You can have various forms of communication. So articles can be written, and in the world of social media, you will see a lot of companies put out things with regards to their products. Post-market surveillance activities, including being involved in post-authorization safety studies or even controlled trials after marketing. We have the drug use evaluation, where we are going to be looking at the products and we're going to be looking at the misuse or errors. And my previous speaker, Dr. Baker, would have mentioned the use of some products that were used during COVID. This is where these would fall under. And then we have the Sentinel system, which is actively going out there into various sites and looking for specific adverse drug reactions to a specific product. So here we will have our first poll. All quality problems will result in a safety and/or efficacy issue. True or false? So again, all quality problems will result in a safety and/or efficacy issue. Is that statement true or false? This answer is actually false, right? It's not all quality problems will result in a safety issue, right? So what are the aims of pharmacovigilance? And we're going to start at the patient level. So we want to improve patient care and safety in relation to the use of medicines. You have to remember that each patient responds differently to the same drug. So we have to start from their level. Once we move from the patient level, we reach the public health system. So if we are improving our patient care, we're ultimately going to be improving our public health system. And of course, this is in how to use medicines. We want to detect problems, and we want to communicate the findings in a timely manner. And I have emphasis on this, and I'm clutching my fist because this is an issue that we're having. So this is an aim that we're not achieving. We want to contribute to the risk-benefit analysis of these drugs. Are they doing more harm than good? And if they're doing good, we want to maximize as much as we possibly can on these benefits. We want to encourage the safe, rational, and more effective use of medicines. And the first thing I think about here when I think about this statement is our antimicrobial resistance. Once we are going to be using our antibiotics in a safe and a rational and very effective way, we can decrease antimicrobial resistance. We want to promote understanding through education and clinical training in pharmacovigilance and this again is an pet peeve, and it's effective communication to the public. And you're going to understand through this presentation that communication, especially risk communication, is an important part of pharmacovigilance. So how do we go ahead and report adverse drug reactions to the Ministry of Health Jamaica? You see a schematic here, and I have included our regional authorities because we do have persons who work in our public health system, and it is important that the regions understand what is going on. This is one of the models that we use during COVID. So we have our patient who reports into the healthcare worker what is going on with them. Now, unfortunately, they're using the paper-based form to report into the regional authority, who would then report to the Ministry of Health and Wellness. Because we're moving in modern times, our healthcare worker now can report directly to the Ministry of Health using electronic means, whether it is web-based or mobile-based. And I remembered many, many years ago when I started working with the ministry, and I was telling you how we went about using reporting forms, and person says, no, we have to get it simpler than this. And I'm happy to report that we're getting it simpler than this. So what happens when it reaches the Ministry of Health? The causality assessment is being done, and that should be done by a team of experts, a multidisciplinary team of experts, not just pharmacists, not just persons who work in the ministry, but all the persons who have an interest in what is going on. When we do a causality assessment, we will then have feedback to our healthcare workers to let them know what's happening and how to prevent and how to minimize. And that feedback then goes to the patient. But you can see in some cases where this needs to be instantaneous. It's very, very important. So when there is a delay, the delay in getting back to the patient is also created. At the same time, because Jamaica is a part of the Program for International Drug Monitoring, we report into the global database, Vigibase. Now, we can't just report any and anything because the global database has certain parameters that we must ensure are there. So I may receive 10 reports and I can only submit 5 to the global database, all right, because it's not meeting certain parameters. So how do we report these ADRs? Again, we do have our manual reporting form. It's still very much available. It's still very much not fillable. So you still have to go back on the ministry's website, find it, download it, print it, fill it out, scan it, and send it in. No, my God, nobody got time for that. So we have our e-reporting, where it's the web and the mobile app. So I want you to take note of this website, bookmark it, everybody, so that you can have it, right? Now, whether or not you're going to be using the mobile device or the web base, you're going to reach to this particular URL. Now, if you scan this QR code, this will take you to that website. Now, for it to become an app on your phone, whether it is Android or iPhone, you're going to have to go to your menu and then you're going to install it as an app. And that is why I'm asking you to kind of bookmark the website for now, because I know some of you may be using your mobile device, so you're unable to scan that QR code. All right? So here it is once again. It's vigiflow-e-forms.who.jm/ADR. Let me just let you know that this form is for drugs and not for vaccines. We actually have another one for vaccines, but I don't want to overwhelm you too much today. So we know the aims of pharmacovigilance. We know how we're going to report, and we now have the tools to report. So what are we going to report? We're going to report all suspected reactions, including the minor ones, for new drugs. So that is why when the COVID-19 vaccines came out, we were asking you if you had pain at injection site to report it. When we talk about new drugs in pharmacovigilance, we're talking about drugs that have not been in use, in Jamaica in particular, for a period of more than 5 years, right? Our laws, I think it's Regulation 64, defines new drugs differently. And if you read the law, it will tell you that a new drug is defined as something that has not been in country prior to August 4th, 1975, right? So so everything after that is a new drug. So for pharmacovigilance, when we talk about new drugs, we're talking about 5 years. So our well-established drugs now, we're going to report all serious or unexpected. All right, so we don't have any documentation with regards to that. The caveat is we also want you to report on increased frequency. So in your pharmacy, if you have a particular drug and persons used to complain, you only had like a handful of persons complaining about the drug, but now you're getting every prescription persons are having a complaint. That is an increase in frequency, and it should be reported. Because this is one of those cases where we may have a substandard and falsified product on our hands. We also want you to report all interactions, all drug interactions, whether it's drug-drug, drug-food, or drug-food supplements. Now, speaking to our patients, you're going to hear that they take these natural products. Now, my colleague is here in the room with me, and one of the classes we got in first year pharmacy school at CAST was pharmacognosy, and that is where I learned that aspirin came from the bark of the willow tree, and that's supposed to be natural, right? So therefore, but we all know that aspirin has been commercialized now, and therefore is going to have its various adverse reactions associated with it. So whether or not they're telling you that they do natural products instead, and they're going to be doing this and they're going to do that. Earlier on, we heard about elderberries and all of those sort of things. All of these have the potential of reacting with other drugs. So you have to do your good drug history. Special fields of interest. We learned about asthma and the various different respiratory illnesses that are associated now. We learned about fertility earlier, so all of those things. I'm sure that my friends at Ferring will say, yes, report on those for us. Let us see what's really happening. And we want you to do with drug withdrawals. And I'm not talking about hard drugs. I'm talking about our regular day-to-day drugs. What is happening to your patient when they come off a drug? Do they tell you how they feel after just coming off the drug? That's very important. Now, most of my colleagues don't like the next point. So, medication errors, whether it is on your part, the physician's part, or the patient's part. Whether it caused the intentional overdose or accidental overdose. We need to know those things because we can work with the marketing authority companies to see how we can better minimize. Medication errors are preventable. We don't need to minimize them, we just need to prevent them from occurring. And of course, the lack of efficacy. Your patient comes and says, no, I don't want that drug there, because it not work for me. Right? We need to know what is on our market, all right? And pharmaceutical defects. You open up your bottle of capsule, your tablets, and you find whole heap of broken ones inside there that you can't sell. And I have to speak to you from your bottom line because you can't sell it, right? So those are the things that we want you to report. However, goal number 2. Which of the following should be reported interactions associated with drugs, all suspected adverse drug events, all non-serious adverse drug events, all of the above, or none of the above. Right? We have, I hear some letters being thrown inside here. So let us see how we are. Where are we? So which of the following should be reported? Can we see the results? All right, all of the above. And for the 4% that says interactions associated with drugs, you are correct. Right? Remember, we wanted to see all interactions. Remember, we don't want to see all suspected adverse drug reactions because there's a difference between our new drugs and the well-known drugs. And yes, the non-serious, but we're more concentrating now on the serious. So thank you very much to those 4% who were paying attention after your coffee break. All right, so now that we know what to report, how to report, where to report, and all of that, there are certain things that we need to report. You must have a single identifiable patient. One patient, one report. When I speak about identifiable, and I'm going to speak now because we have the Privacy Protection Act, the Data Protection Act, I'm not talking about I am going to look at this report and I'm going to know, oh, this is Julian Gemot. No, this patient, you must know who they are because you're going to be having a habit now of reporting, so you're going to have to know patient A from patient B from patient C, especially if it's the same drug and it's the same sort of event that is occurring. So you can, on the documentation, provide their initials or their docket number, depending on what area of work you are going to be in. Now, for you to have a report, you must be reporting an event, or you have a suspicion of an event. So don't just tell me that patient X had an adverse reaction. Tell me exactly what the reaction was. When did this reaction occur? Did it happen before or after? I think the worst report I have ever seen, and persons would have heard me say this numerous times, is that patient took Viagra and died. I don't know who the patient was. Was it male? Was it female? Was it a child? Was it an adult? Right? What were they taking the Viagra for? What did they die of? They could have died from a car crash. Who knew? Right? So we're now looking at the substance. Now, some of our patients, especially our cardiac patients and our renal patients, have what we call shopping lists. So we don't know exactly what it is that may be causing it. So we would need to indicate all of the products that they're taking. Your job is not to do that guesswork. Your job is just to report. And your job is to let us know who you are. Because if we have a concern or we need more information from you, then we will be able to contact you to get an update. All right? So we have our minimum reporting requirements. Oops. We have our minimum reporting requirements. So how do we use that together? Now, pharmacists were not really taught how to write narratives. And it is a narrative that drives the reports. It tells a story of what is happening. So when we're looking at the four areas that we're supposed to be reporting on, we say JJ is a middle-aged female of African descent. She has asthma, hypertension, diabetes, and you name it. She was prescribed drug X for P condition since 2017, and on 3 days after she took the medication, this is what she had, right? So you are writing a narrative about the product and the whole event so that we can see what was happening to the patient. So of course, we're going to have to speak to the patient to get a lot more information. And I know UTech has in their program, you know, when we do medication, drug interviews. So this is where all of those skills are going to come into play now. Now, we're asking you for all of this because why are we reporting? We're reporting to detect signals. These signals are letting us know that something is about to happen. These signals are like our amber light. You know, when we see that amber light, we know it's going to turn red. Some of us, we rush through it same way, but others, we slow down, except if you're in Montego Bay. If you slow down, you're going to get somebody hit you in your back, right? Now, when these signals occur, they suggest to us a new event is coming on that we never knew about, or that the adverse event that we thought we knew has a little twist, and we need to do further investigation. What the signal does not tell us that the event is associated with the product. We are not saying that there is a causal relationship at this particular time. We create a hypothesis, so that is a question in our mind about the event and the product. We normally use more than one case study to help us to determine if a signal is being emitted, and even within those signals, there is noise. And therefore, we have to remove the noise and then get to the meat of the matter. So in signal detection, you can use quantitative or qualitative data. In your quantitative data, you're looking at your large data sources. Jamaica don't have a large database. Let me just tell you that from now, right? Because we're not getting the reports to identify these signals, and the reports that we're getting, the quality of them are not very well. We also have case control studies, and we have intensive hospital monitoring. So for our pharmacists who are in the hospital, here is your chance to shine, right? And then we also have prescription event monitoring occurring. In your qualitative, these are your spontaneous reports that you're sending to us. So these are the reports that I will be receiving on a daily basis. I can also be looking at literature reports or hearing the noise that is going on, not just in social media, but internationally through my own networks. We also have intensive hospital monitoring, where we can actually use the hospital as a sentinel site where we're actively looking for a particular event. And we also have follow-up studies. So in signal management, we need accurate and complete reports being sent in, right? So when you give us a very vague report, it's not going to help us to do anything. Persons will going to say, so you detect any signals yet? I sent you a report, it triggered a signal? It can't trigger a signal if the quality is not there. So proper collection of the information, we need your follow-up reports, because we do know that there are times when you're not going to get all the information at once to send it to us. And therefore, we're going to have to be following up with you to see, did you get more information? I've had instances where I've gotten good cases coming in and I asked for a follow-up, and then the crickets started to chirp, right? We also have to make sure that the source that we're getting the information from is very, very good, reliable, all right? Because we do get patients reporting, and we do have persons sending in reports that are also noise. When we get these reports, we have to code them. So we actually use the medical dictionary for regulatory activities, that's called MEDRA, and that is also used to search international databases, because that is how everything is coded before it is sent into our global database. And then we're going to do our assessment. So we're going to do our causality assessments here, and then we're going to use certain tools to do our analysis. So We're going to identify the data sources. We're going to see whether or not we have gotten multiple reports that we're going to be getting a signal. We're going to prioritize those signals that we're going to get, shift out all of the noise, and evaluate what we have left. We're going to make an analysis of that data, make an assessment to state that this product is actually causing this, and then there's going to be a call for action. This call for action can be at the regulatory level, and it can also be at the marketing authority holders level. Some of these activities include update in the package inserts or the summary of product characteristics, right? So sometimes you might not have a product because there has to be a variation to the package leaflet, and that is taking a little while, so we have to make sure that the information in the package leaflet addresses certain new concerns that they have. There may have to be a risk management plan put in place or update of that risk management plan that will include measures to minimize what is going on. We also can put in urgent safety restrictions. So if we notice that in this population, this is what we're seeing, we can say, when you're going to use it in this population, you have to put in these things. Some of the things that can be included here are your patient registries. And some of you are familiar with patients even signing contracts before they're even using a medication. And the last one, which we really don't want to see, is withdrawal of the product. However, when this happens is because all other things failed. And that is really the final straw. So, let's talk a little bit about Vigibase. So as of June 16th, 2025, there were over 42 million case reports in the global database. 42 million, right? We're in the region of the Americas. So we had a little bit less than 50% of what is in the global database. So we're in a good region, right? Don't get too complacent, however, because things are changing. Now, if we take out our neighbors to the north, that includes North America and Canada, we go down to 1.7 million, right? So that is Latin America and the Caribbean. If we take out Latin America and just leave the Caribbean, and I'm going to say CARICOM here because not everybody in the Caribbean is members of the program, we now come down to less than 5,000 cases within our little region here. Jamaica, we have currently over 2,000 cases, which is 0.006%. We never reach 1% in the global database, all right? But on the good side, Jamaica has over 50% of the cases in CARICOM, right? So we're leading. We're leading in that case, all right? Other countries are coming up close, but we're leading at this time, right? So what's been happening? Are we reporting to the ministry? You would say yes, but I'm going to say no. Because what's been happening is that our medical representatives, our sales representatives are going to the doctors and are interviewing them about their products. They are obligated to make those reports. And as a result of that, they are reporting on behalf. So our initial reporters are our physicians because that's where a lot of these medical representatives are going. Where you see other health professionals, those are basically our nurses. And I must commend our nurses at the Cornwall Regional Oncology Department because they are using our portal on a regular basis to submit. Our pharmacists, on the other hand, oh, my something never come out good. Our pharmacists we are less than 9%, right? So we're poised to do better. We're poised to do better, and therefore I'm encouraging you to do better. So let us look at the total thing of what Jamaica is doing. So we started submitting into the database in 2013. So you see our numbers. Nobody was around in 2016, so nothing was happening. All right, so that's why you don't see anything there. But what happened in here? COVID, all right? And that was a 4-fold increase in the number of reports that we got, all right? So, and you notice after we stopped receiving reports, what happened? We went back down, all right? So that is what was happening in the Jamaican sphere as it relates to the reporting. So here we have Mr. COVID, 2019 to 2023. So November, December, WHO was watching this respiratory illness that was coming out of Wuhan, China. January 12, 2020, they confirmed it as a novel coronavirus, COVID-19. March 10th, and Dr. Baker would have told you about some of this data. And March 10th is in my head because March 10th was also the day before I had my US visa appointment. And I had just driven into my gate when I got a message on my phone. Your appointment has been canceled. Right? I didn't know that what it said before. I had glanced at it and I just saw it was coming from the embassy. And I said, oh, they're sending me a reminder. How nice of them. So by the time I went inside and read the message and to see my appointment has been canceled, I said, how they can cancel my appointment? Right? So March 11th, COVID-19 was declared a global pandemic. And in March 12th, we had our vaccination rollout. So what was our pharmacovigilance response? This was a time when there is now a new collaboration between the expanded program of immunization, which was housed by the Family Health Unit in the Ministry of Health, and standards and regulations. So now we could exchange data and work together. We realized that we had separate reporting forms, and that therefore required us to merge the forms together to form a form, not just for COVID, but for vaccines at that particular time. We had to train our healthcare workers with regards to the use of the form and how to report. And we had to disseminate these forms to the field. A multidisciplinary team was formed so that causality assessment could be done. We had to collect these reports. These reports had to be coded. So every single reaction that was there, every single indication that was there had to be coded. And at that time is only one person was doing all of that. We were also having to follow up with the regions because we would require them to have various different documents provided to us. Because the work got overwhelming, you saw that increase in the level of reporting, we hired 2 new PV consultants who also helped in coding and doing the follow-ups. The team of the NEC would do the causality assessment, and the chairperson of the committee would provide feedback to the regions of what was happening as it relates to the ESAVI cycle. So, again, I'm scoring myself because I was involved. I know I worked very long and hard. And I'm giving myself ticks for the first 2, half mark for the third because of the communication, ticks for the first 2, and no marks at all for that effective communication for the public. And therefore, I'm giving myself, for the PV response, a 75%. All right, I hope nobody argue. I still pass. I did what I could, and I could what I did. Yes. Right. So let's go on to our third poll. What is the number 1 factor preventing you from reporting ADRs to the Ministry of Health? No, this is a free form. Oh, I had really wanted it a free form, but all right. You don't know how to report. All right. You want me to do what? I don't got time for that. right? So what it is that you're thinking, right? So what is the number one factor preventing you from reporting? I think we can look at the results now. You don't know how to report. So I hope after this morning, you will know how to report. All right? And this isn't a right or wrong. This isn't a right or wrong question. So, so you see how him look vexed? Right. So now you already know that you need to report. And I hope that you would have got the information on how to report. Our law in Regulation 70 says that you are supposed to report. And that is why I said it is not voluntary, it's actually mandatory. Right? So what is your role as a pharmacist? I want you to actively participate in drug safety because this is what it's all about. I want you to monitor your patients for adverse drug reactions regardless of which field you're in. If you're in the hospital, if you're a medical rep, if you're in manufacturing, if you're in the community setting, these are things that you can do at your level. I want us as pharmacists also to step up and get involved in post-authorization safety studies and or clinical trials, because that is where you will shine. Not only do I want you to do all those things, because these things will help you to recognize adverse drug reactions, but I want you to document them. And I don't want you to just document and put in a file. I want you to document to report them. And when you're reporting them, try and give the complete information available at that time. I want you to follow up your patients as well, so that if you get more new information as to the case, it can be applied to the case so that we can better aim to do well for our patients and the public at large. And lastly, I want you to publish. 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 I got a signal coming out of the UK where it talks about the likelihood of melanoma to occur, non-malignant melanoma to occur in patients using hydrochlorothiazide. And I said, let me go to my dermatologist. Are you seeing this? Are you seeing this? And, you know, they said, not really, not really. And lo and behold, they started to see and they published. They never reported it to us. But because I still do literature reviews, I was able to see that a publication came out of Jamaica surrounding that matter. Now, what are the new trends? Everybody is talking about AI and machine learning, and pharmacovigilance is no different. So, robotic process automation is another area where pharmacovigilance is used. And what exactly it is, it's a software robot, or bots as they're called, that is used to automate repetitive action. So you saw the young man telling you, saying, don't have no time for X and don't have time for Y. RPAs are going to do that for you to help you to report. So here are some of their applications. Adverse drug reporting. For those of you who are in the industry, it can help you with your regulatory submissions, help you to generate your PBRs. It can also be used to monitor your compliance, that you're submitting your PBRs on time. And in the regulatory aspect of the Ministry of Health, we can use it to see whether or not you're submitting on time. You can also use it to evaluate your data to see whether or not it is true or false. It is rarely used nowadays for signal detection and analysis, and therefore it's not really used to that extent, as we are now going into artificial intelligence and machine learning that actually do that job better. So what is AI? It's systems exhibiting characteristics associated with intelligence in human behavior. And machine learning is the ability of computers to learn without explicitly being programmed. And every time that I see this, I think about the Will Smith movie. Now, machine learning is a branch of AI, and I won't go into deep learning. Deep learning is still fuzzy within the pharmacovigilance sector. So AI and machine learning, it helps you to detect adverse drug reactions. So what you're now going to do is going to use this, you're going to write a program that is going to go and into, so in some hospitals now we have the electronic health records, so they can go into the electronic health records, look out for keywords and stuff like that, and therefore be able to detect these reactions. Again, signal detection and analysis, so it is going to help us with our signals and to analyze the signals. Detect drug interaction, so again, using the databases that are there, it will be able to go in and find this information. And also, because it is learning as it go along, as the case may be in machine learning, it will better be able to predict who is going to have an adverse drug reaction in the future. So when we're looking at the task, there is the data ingestion, so that is the reporting in, and that is, you're going to be looking at your duplicates, because that is another thing. Sometimes you might get multiple reports for the same case, so to do a proper thing, you have to remove your duplicates. You have to identify any outliers as well. And then your signal detection activities, you're looking at your patterns and predictions of adverse drug reactions. So you know if this patient is going to have an adverse drug reaction, what you can do to either prevent it or minimize it in the future. So how are we looking for the way forward? We need to plan for our future. And one of the things is that we need to improve our legislative framework and enforcement. When I look at what other countries have for their pharmacovigilance framework, and we only have regulation 70, I cry. When I go on the international scene and we're talking, and language is not a barrier, even though I pretend it is, I cry, because they have volumes upon volumes upon volumes. And for those of you in the industry, you're going to hear about pharmacovigilance audits very soon, if you have not already, right? Build out the pharmacovigilance framework within Jamaica, but we need a legislative framework to stand up to first. We need to create a culture of reporting, and we have to make sure that our systems are interoperable. We have pharmacies using multiple different systems, right? And therefore you want one general system that can use everything, or they need to be able to speak to each other. We need to improve on the quality of the reports that we get. We need to be more informative with these reports so that we are able to do signal detection. By doing this, it is hope that we'll be able to reach our sustainable development goal number 3. Thank you very much.
Thank you. That was amazing. All right. So let's see if we have any questions. The ones, a lot of ones, whole heap of ones, and applause. All right, guys, do we have any questions? Post them in the Q&A. Not seeing any right now. I actually do have 2. Thank you. Thank you. I forgot. How long after an adverse event can one reasonably make the link to the product? Sometimes it takes a while before the adverse event shows up, such as changes in menstrual cycle after receiving a vaccine.
All right, so an adverse drug reaction can occur at any point after a person has taken a medication, and it doesn't necessarily have to show up within that person. There have been cases in the past with diestralstilbestrol that resulted in the mother taking the product to prevent a miscarriage, and the event took place in her teenage child many, many years later. So I can't say 2 weeks, whatever, but You just have to kind of see what is happening with the patient and just use your suspicions and report.
Thank you so much. Is the ministry planning to do audits or enforcement of distributors who are all mandated to at least report to the manufacturer?
Well, you heard that we have to build out our framework, and we cannot go in without having a framework and sensitizing persons before we act. I'm not here really representing the ministry, so I will not go too much further into that.
All right, thank you very much. Any questions in the room?
Yeah,
Yeah.
That's,
We're hearing you.
okay, great. All right, thanks, Drummond. That was eye-opening. That was eye-opening, actually. One of the question I want to ask you though is you mentioned the challenges with reporting. You're obviously not satisfied with the level of reporting. However, I want to know what percentage of the reports that you get are rejected. Because you're not happy with the quality of the reporting at some point.
We don't reject reports, right? And we have received reports from our consumers. During COVID, we received a lot of reports from anti-vaxxers, but they're still reports.
Maybe I should qualify the question a little more with the quality.
Oh, okay.
The reports that cannot be submitted into the global region because
All right.
quality is...
I would say that it's less than 5%, less than 5%, because unfortunately, once it meets those 4 minimum requirements, it's reportable. The quality still not be there, but it's still reportable.
Any other questions in the room? Because of the Sunday dinner and your wonderful presentation. Okay, I have one here. Can vaccines be reported for adverse effects? Example, the COVID vaccine, where some patients reported having heavy bleeding or adverse changes in their cycle.
Okay, I have to sit up straight for that particular one. We had a whole campaign with regards to the reporting of adverse events associated with the COVID vaccine. I saw multiple anecdotal reports floating around in social media, in WhatsApp groups, but nobody was reporting. And I was flabbergasted with regards to persons not reporting these things and then saying that we're not doing anything about them. I remember during COVID, because I had many sleepless nights, and I actually had a presentation to healthcare workers one night when there was a tropical storm outside. My lights had gone, and I had actually had to be on my backup generator, turning off everything around me so that I could present to healthcare workers of what they're supposed to do when they see. I showed you earlier on in the presentation where we formulated a special reporting form for vaccines in conjunction with the expanded program on immunization through the Family Health Unit. Therefore, we had expected and anticipated persons to report. I did receive, I think, 1 or 2 reports of the periods with regards to the COVID-19 vaccine from a pharmacist, and I appreciate that. But for the most part, our pharmacists were very, very silent. We had a lot from the patients reporting it indirectly, and we had a lot coming from our doctors. But again, our pharmacists were very silent, reporting into the COVID-19 program, but were very, very vocal on social media. And I was very sad for that, being a pharmacist myself. And I know that we did go out there telling persons that you need to report. And because the COVID-19 vaccines fell in the category of a new drug, we expected persons to report on everything.
All right, thank you very much. What is the approach of adverse drug reporting for patients on multiple drug therapy?
Well, because we don't want them to assume it is any particular drug, and let me just make sure, I'm going to answer this in two different ways because I'm not too sure if I'm understanding exact context of the question. So a patient wants to report, and therefore you want them to report on everything. Or is it that you have a patient who has multiple drugs and you want to rule out by reducing the drugs, right? So there are some physicians who will do that by ruling out, by taking them off medications. But again, we have to be very, very careful with that. And in pharmacovigilance, that is actually what is known as a D-challenge. So when you take the patient off the suspected product, does the reaction disappear? Now, that may or may not disappear depending on the type of reaction. So if it's a failure in contraceptive and the patient got pregnant, you can't reverse that, right? However, once you reintroduce the product, that is known as a re-challenge if the event occurs, and that can symbolize that it was the product. So I hope that that explanation helped.
Wonderful, thank you so much.
We have to report when a pregnant person takes a product.
Most definitely, because that is what we call the special fields of interest, because we want to know what happens. And going back to the 1970s, 1960s with diacetylstilbestrol, this was sometimes when we didn't do carcinogenicity, embryonicities, and all of those toxicological effects in testing of products before they come on the market. So that kind of told us now what was happening. And it will give us a better understanding. And sometimes we use data of somebody's bad event to prevent or minimize the future events.
What about positive?
Oh, most definitely, most definitely.
Positive adverse events.
Yes, and there are positive adverse events, and I will look at it in the Jamaican context where there is a popular antihistamine, right, that is not used as an antihistamine, but it opens up our appetites, and therefore everybody now wants it. Right? So I remember when I just joined the community pharmacy world, can I get the vitamin X? And I'm like, but that's not a vitamin. Yes. Right? So there are actually positives. And the little blue pill came out of on a positive for some persons, right? Because it is used for pulmonary hypertension, and therefore during the studies they recognized that these persons were reluctant to return the samples because of the benefits that they were reaping, and therefore they decided to explore those benefits. So sometimes when we talk about the drug utilization evaluation studies, what we're looking at is how the drug is being used, because there's times when persons are using drugs in a certain context that they were not originally marketed for, but then physicians can have their free will and use the product, get in the benefit, report on these benefits, have the data to support the benefits, and therefore you have new drugs.
I just ask one thing though. In a matter of reporting, let us say a client came to us to report something who might feel like the drug is not working. And as a pharmacist, you evaluate the situation and realize that they weren't using it properly. And you explain how to use it, and then the circumstance change. Do you still report?
Yes, because
that the client had actually reported it to you?
Yes, because you've only helped one patient. How many others have you not reached out who may be also having that problem? So it's important. It's important.
All right, thank you very much. And we'll post the link to the reporting that you shared in the
Thanks ever so
chat.
much for that.
Ladies and gentlemen, round of applause for presenter,
So,
Mrs. Julia.
Mrs. Robinson Jamot, we just want to thank you on behalf of Aventa Jamaica for this very, very educating presentation. Pharmacovigilance is very near and dear to us. We have been audited, and I'm sure there are more audits to come. So thank you so much.
Right. And I hope that there will be a part 2, so I can speak further on substandard and falsified products. Another hot topic.
Oh, God. Thank you very much.
Welcome back to this. Welcome back to this half. We want to thank Julie for a great presentation. The message is pharmacovigilance is here to stay. And we cannot say we don't have an update because we have e-reporting, we have a mobile app, we have QR code to capture and all of that. So let's get going with it. I know here at Aventa, part of the language spoken here is pharmacovigilance. And I'm grateful for that. We have some good news. We have a winner. We have a winner for the mnemonic competition. We do. Don't we?
Sure.
Yes, we do. And that winner is Jessica, drum roll, fabulous, Jessica Johnson. Clap, 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 clap. And Jessica sent us and she said Aventa, A stands for advanced in research and development, V for visionary, the approach that Aventa takes to healthcare, E, expert, teams, they're expert teams of professionals, N for nurturing, a commitment to patient well-being, and T for therapeutic, which is innovative treatment that we bring, and A, aspirational, striving for excellence. Congratulations, Jessica. Your gift basket is on its way, and we're grateful for that. We have other winners. From the top 15, Shanique Morgan Thomas. Am I correct in saying that this is Ammonia Wheatley, or yes? Janelle Harvey and Almantha Zinkney, or yes, Zinkki. And so those are all the 4. So we have 3 more names to release for our top 15 registrants this morning. And we're going to go right into our next presenter. Yeah? And to talk to us on recent updates on OTC classification is no other than Dr. Alina Langley, well known to us as a senior pharmacy inspector and education officer of the Pharmacy Council and the Ministry of Health and Wellness. So it is within this capacity that we are going to bring to you via video, Dr. Alina Langley to speak to us on the recent updates on OTC classifications. Good to have you, Doc.
Good afternoon. Thank you so much. Thank you to Aventa for having me this afternoon. Interesting presentation so far. So let's get the ball rolling, shall we? All right, so this is a topic that we'll be looking at this evening. I trust everyone is hearing me. All right.
Hey, Doc.
And these are the objectives that we have for this particular presentation.
Hey, Doc,
We want to look at the legal framework. We want to look at some commonly confused products.
Hey, Doc, can you hear
We
me?
want to look at the reclassification process. We want to identify some key factors and considerations that go into that process. We want to look at the benefits associated with that process. And of course, we want to look at the role that pharmacists play in that process. So let us begin. Now, the legal framework for classifying drugs primarily involves the Standards and Regulations Division through the Food and Drugs Act of 1975, as well as the Pharmacy Council through the Pharmacy Act and Regulations of 1975. Just a second here.
Hey, Doc, hopefully you hear me.
All right, so my apologies for that. I was told that you are not seeing the slides. Hopefully you're seeing them now. Right, so I was making the point that the registration and classification process is shared by these two functionaries of the government. Now, many pharmacists will remember from forensic pharmacy that these two pieces of legislations are described as sister legislation because they're shared sections. Sections impact on each other. So they're not necessarily complementary in the strict sense of the law, but they're definitely sister legislation. And so you will have aspects that are intertwined and are reflected. But when we look at the Food and Drugs Regulation, which actually arises from Section 21 of that Act, it provides a definition for items such as controlled drugs and list 4 drugs. The Ministry of Health, of course, plays a crucial role by setting the requirements for the registration of all drugs. The Pharmacy Act not only establishes the council and outlines its functions, but it also details the classification into which drugs are placed under Section 17. Additionally, and importantly, the council is a regulatory agency which is responsible for the classification of drug products into either list number 1 or list number 2 products. So prior to classification, the drug must first meet the registration standards set out by the Ministry of Health through the Standards and Regulations Department. And this is done under the Food and Drugs Act. Conversely, the condition of sale for drugs and how the public accesses them is the legal mandate of the council personnel and the processes respectively. And this is done under Section 25 of the Pharmacy Act. Now this slide is going to be a little bit busy, so I'm going to ask you to bear with me because under Section 17, it defines the 4 lists of drugs that we have locally. List number 1 are those for free sale, do not have to be stored in a pharmacy or sold under the supervision of a pharmacist. We have list number 2, which are the pharmacy-only drugs, those which are to be found in a pharmacy and sold under the supervision of a pharmacist. We have list number 3, which we all seem to studiously avoid unless we have pets, do some farming, or we happen to work in pharmacies that stock these drugs. And finally, we have list number 4, which are the prescription drugs. And you should note here, let me just advance this, that it says the Food and Drugs Act, and remember this is the Pharmacy Act that we're quoting from now, prohibits these from being retailed except on or in accordance with a prescription from an authorized prescriber. And so here is an example of the laws being intertwined as the Pharmacy Act is making reference to the Food and Drugs Act, which defines list number 4. Also, you will notice the last paragraph in this section. It sets the basis for the whole presentation, basically. And this is a process that we will look at shortly, that of reclassification. Because here, the council is permitted, let me just make this a little larger for you. The council is permitted to amend or vary any of the specified lists, 1, 2, 3, or 4, by publishing a notice in the Gazette. And here we will pause for poll question 1. So we actually touched on that, and I'm interested to see what the responses would be. All right, so I see we have suffered very little ill effects from that break. I'm seeing that 61% of persons indicated the correct answer, which is the Pharmacy Council. Right, so this is not an error. I am hoping that the song didn't play in your minds, but if it did, it is a good way to be on your P's and Q's when it comes to the conditions of sale. Now, there are 3 conditions under which drugs can essentially be sold. These are the places other than a registered pharmacy and only under established conditions. Within a and of course that would be list 1. Within a registered pharmacy under the supervision of a pharmacist without a script, that would be our list 2s. On a legal order provided by an authorized prescriber, and of course that would be our list 4s. Now, you may have some misconceptions or some confusion that may arise based on the permitted quantities, particularly under list 1 and 2, since we're looking at classification and reclassification this evening, defined strengths as well as specific situations. And so I have a list here, which is by no means exhaustive, where we have some commonly confused drugs and the conditions of sale are usually confused. Now, I want you to look at this list, and can someone quickly in the chat just indicate, or you can open the mic if you're permitted to, tell me which one of these drugs was reclassified. Just scan those 2 columns.
If you'd like to answer, just raise your hands.
Classification and relisting are technically the same thing. All right, so I'm seeing some responses coming in. Right, I'm happy this wasn't darts because a lot of persons would have missed the bullseye. All right, so these are all list number 2 drugs. And I think I understand why persons would be pointing to acetaminophen. Acetaminophen was actually moved from list 1 to list 1. Technically, it's the quantity that was changed. It was a minimum of, or a maximum rather, of 24s that could be sold anywhere. That was changed recently to hundreds, but it wasn't changed in terms of which list it was on. In truth and in fact, it is actually the terbinafine that was relisted recently, and levonorgestrel before that. So those are the 2 drugs that were relisted. So, and I see persons pointing to fexofenadine. Fexofenadine is actually a list 2 product, has always been. All right, so before we can look at reclassification, we want to ensure that we're on the same page as it relates to classification and the process that is involved for drugs which are sold in Jamaica. So this process is rigorous. We won't go into too much detail, but I want for us to have an understanding of how drugs end up on our free sale list and how they end up on our pharmacy only list. And it begins with the receival of the registered drug product from the Ministry of Health, Standards and Regulations Division. The physical product and the registration documentation is sent to the council. This documentation contains the product name, the registration number, and the local distributor, along with other information. Initial research is done, and don't be fooled by the term initial, it's actually comprehensive, looking at all the ingredients, active and inactive, the recommended dosage, side effects, drug interactions, etc., looking for previous classifications associated with the ingredients in the particular product to be classified, as well as any data from other jurisdictions. The inspectorate within the council normally does an initial review of all this information and proposes recommendations to the list committee. Now, the list committee is a subcommittee of the council, and they operate under a mandate which says they ought to do no harm. So none of the decisions you should have any harm flowing to the general public from that. And that is why the process is as rigorous as it is. So the research that has been put together, the inspector's recommendations are reviewed along with any other pertinent information that the committee may request. And they would essentially be looking for any therapeutic claims that are being made, the general health safety associated with this particular product, the potential for harm, and certainly Jamaica being a tropical country, product stability. They then make a recommendation to the council board, which then does its own deliberations and comes to a final decision, often based on the recommendation and any other questions that they may ask and information that they may seek. Once the product has been classified, correspondence is sent to the ministry detailing the list to which it has been classified and any special conditions associated with that. And then upon formal publication in the Jamaica Gazette, that product is now legally listed and approved for sale. Right. Now, the WHO champions a particular position, and it is important because it describes a very objective and the push for reclassifying drugs, which is what we'll go into next. It's making it more available, but guiding and setting boundaries for the use of these particular drugs. So the current reclassification process involves a detailed sequence of steps, which begins with the proposal and basically ends at the same spot as the classification process with official gazetting. It is similar to the classification process, but of course it involves a bit more, certainly on the part of the council and on the part of the applicant. And I want to point out here that while movement may be up or down the list, majority of the requests are for products to be moved from list 4 to list 2. So the process begins with proposal submission. And this proposal can be submitted by any registered pharmacist, a registered distribution company, or from time to time, it may be internally generated at the level of the committee, being the list committee or the council itself. We move to the initial review of the request. And here the list committee looks at what is being requested. If they are in agreement with it moving forward, then the applicant is advised of a date and time for the presentation. And this is not saying you apply on Tuesday and we tell you you can come in and present the very next Tuesday. Of course, it's a dialogue that takes place because it's not a presentation that is strictly about the drug. There's other information that will be required. And before, I think, let me just preempt one of those questions that I may get at the end. The cost currently, notice the use of the word currently, it's $7,000 per item to be reclassified. So once accepted, arrangements are made for the formal presentation to be made to the list committee. This presentation must be conducted by a registered pharmacist and of course should include comprehensive information on the drug product. In that presentation, information on health safety and the actual usefulness of that drug should be included, along with any expert feedback or studies related to the particular product, the manufacturer's findings. We've looked at post-marketing surveillance or phase 4, which I have listed here, any relevant international, regional, or national policies, as well as any proposed labeling changes, because if it is going to be moving to a list 1 product, we want to ensure that any person who goes into, and I like to use the term from a handcart to a gas station, they should be adequately armed and provided with information to safely use that product. And speaking of national policies, I'm hoping that there are those among us who will remember when some of our anthelmintics were re-registered or reclassified rather, to ensure that we could address the burden of the burden among certainly our school-age children and persons in rural areas. So or albendazole, for example, is actually a list 1 product to ensure that it is available to persons all over without having to go to a physician or go to a pharmacy. Continuing, once the list committee does its evaluation, they usually look at the presentation or any documentation that was presented, any relevant research as well that may be done after the presentation. They formulate a recommendation for submission to the council. Of course, this would be for ratification. The board will then review this recommendation and make its own final determination. And the decision can be either an approval or a non-approval. If it is an approval, well, both decisions are communicated, but along with the approval, the applicant will be provided with the requirements for the next step in the process. And here is where the process clearly departs from the classification process we looked at earlier, in that once approved, there are additional steps which are required to ensure that the training of pharmacists is done and that the persons delivering the training are also approved. And it also serves to set the standards for that particular activity. So you'll notice that the applicant is required to provide details on a training program for pharmacists to ensure that once the condition of sale has changed, they can now properly counsel, properly interview, and properly dispense to patients. We also insist that a 75% of all registered pharmacists in country must be touched by this training program. And so the applicant will need to provide a detailed geographical and chronological schedule to show how it is they're going to be doing this in a reasonable time. Any other supporting documentation, such as visual aids, etc., should also be provided to the council. Importantly, the training objectives are also to be provided because those will also be reviewed. And I spoke earlier about the persons who are delivering that training. Now, the Education Committee, which is another subcommittee of the council, is the one that will actually review this training program. We'll look at the documentation to be utilized, we'll look at the objectives that are set out, and we'll look at the bona fides of the persons who will be delivering this particular training. After the committee has satisfied itself, it will provide a recommendation to the list committee. The list committee, once it sees that all its requirements have been met, will then recommend to the council that clearance be given for this applicant to commence the training exercise. Of course, the training is monitored and it is evaluated by the council for adherence to all of the requirements that the applicant would have set out in the documentation. After the training is complete and evaluated, of course, the list committee, once it satisfies itself, will make a request to the council for the list, the particular list to be varied. And in the law, you will see notice to vary the lists as the term used. So if it's 4-2, if it's 2-1, and remember it can be 2-4 as well, depending on the request that has been received. Once that has been approved, the chair of the council will formally write to the Minister of Health. Remember, we looked at Section 25 of the Pharmacy Act to indicate that they're seeking authorization for the particular list to be varied. And here we now dovetail back to the process that we looked at with classification, where the new condition of sale will be gazetted and the product is now legally listed under that particular list and approved for sale with these new conditions. And so we move into poll question number 2. And I'm hoping that the answer is jumping out at the participants. All right, so that one we zinged a little left when we should have zinged a little right. It's actually calcium carbonate, tablets 500 milligrams and greater, that would be list 2. Everything else there would be list 1. So looking at some of the updates associated with the reclassification process, in May of this year, the council had a stakeholder meeting at which the representatives of the Ministry of Health, Standards and Regulations Division actually announced that they would be looking to improve their registration process for drugs. And in true Jamaican fashion, what doesn't fall on the head falls on the shoulder, because if that process is improved, you can see where it will improve the classification as well as the reclassification process, because it will make it more efficient. And because we have to interact with that process, and when I say we, I mean the Pharmacy Council has to interact with that process, it will make it more efficient for our applicants. Now, squarely on the Pharmacy Council side, there is definitely a push for legislative modernization. I saw where Mrs. Jamot actually made reference to the need for the legal framework to be revisited. We are both dealing with legislation that will be 50 years old this year. And it has been tweaked over time, but there needs to be, some more general overhaul of the legislation itself. An introduction, of course, of an updated regulatory framework is important. And what is also important, certainly as we look at the presentation today, is the promotion of a wholesale review and updating of all of the lists. For example, list number 1 was last published in 2001, and it was updated in 2009. So you can see that there is definitely a need to have these lists revisited. Now we're narrowing it a little bit in terms of the push factors. So the importance of reclassification and promoting access, as well as advancing self-care for patients and customers, is actually very important. Certainly when we consider that pharmacists are advocates of patient care. So we want to look at some of the key factors and regulatory considerations that go into reclassification. Of course, we want to ensure that we're weighing the right factors and making the correct considerations in this particular process, because as you can see, it is actually quite complex and it involves scientific, clinical, as well as public health factors. So when we look at the safety profile of the particular drug, we want to ensure that it has a well-established safety record. We want to ensure that the potential for side effects are minimal, somewhat predictable, and definitely easily managed. And of course, this should be done without the need for a physician's supervision. In terms of the efficacy for the intended use of this particular drug, it must, of course, demonstrate consistent and reliable efficacy for persons who will be self-diagnosing, and of course, for the treatment of easily recognizable conditions. The risk of misuse or abuse should also be of key importance. The particular drug must have a low potential of misuse or even dependence. The benefit risk factor must also remain favorable without any medical oversight. The ease of self-diagnosis. Certainly when we speak about our list 1 items, we want to ensure that the information that is provided allows persons to make informed decisions. And we're looking at the treatment of conditions involving pain, headache, allergies, that sort of thing. The products must obviously have clear labeling instructions. Adequate consumer information must be provided to ensure proper use. The packaging, the leaflets should obviously promote self-selection and responsible use. And again, this is very important for list 1 products which are available everywhere. In terms of the duration for use, these products should be suitable for short-term use as part of self-care. We understand that chronic or complex conditions usually require continued medical oversight, and so patients should importantly, especially when it comes to the list 1 and list 2 items, be given information on how long to self-treat and when to seek referrals or visit their primary care physician. Post-market surveillance and pharmacovigilance. I listened with rapt attention to Mrs. Jamot's presentation. Continuous monitoring is essential, especially post-reclassification, because you now have greater access to the particular drug product, especially if it's a product that is moving from list 4 to list 2 or list 1. And so as regulators, we may want to ensure that there is a risk minimization plan that is worked in, as well as the advocacy for special labeling. In terms of the experience in other countries, this is also a key factor. We want to know how the product is classified and treated in other countries. The public health impact is also a key consideration. How will this reclassification affect health equity? Will it improve it? Will it improve access? Will it serve to enhance self-care practices among the population? Or conversely, will it cause a burden on the healthcare system, which is what we're trying to avoid? And so if we look at what the WHO promotes, it is that the reclassification should augment access and reduce the burden not only on personnel, but on healthcare systems. In terms of stakeholder input, and this is important, consultations with pharmacists, physicians, patient advocacy groups is important. For persons who may remember, this was the case for the reclassification of levonorgestrel from list 4 to list 2. There was a lot of discussion that took place before that change was made. Importantly, the pharmacist's role and level of training. So when we're looking at pharmacy-only classifications that will obtain once a product is reclassified, top of mind must be the fact that pharmacists, of course, are adequately trained to advise and to intervene appropriately, as well as to uphold the conditions of sale. When we looked at the 6-step classification process, as well as the 11-step reclassification process, we can see that both of these are involved, they're complex. And what they do is they require us at the end of it to maintain the conditions of sale and access for these particular drug products. So why does reclassification matter? We have looked at some of these in part, but we want to emphasize it. It is to improve access to medication. Certainly, WHO is on board with that. PAHO is on board with that. Of particular benefit and impact is when you have products that are available to patients who may, for whatever reason, be unable to access their physician. Greater access will promote timely treatment, especially for minor or self-limiting conditions that can also help persons to prevent complications from developing. Instead of sitting and waiting, persons have access to products that they can use. Of course, it will reduce the load on the healthcare system. It allows health professionals within the pharma system to focus more on complex or urgent medical cases. It helps to reduce the waiting times. Instead of everyone going to primary healthcare, it allows persons to have other options. It helps to lower administrative costs, and it also reduces unnecessary consultations and the need for prescriptions. Importantly, it helps to empower patient self-care. When supported by proper pharmacy guidance or pharmacist guidance, certainly in the case of our list 2 items, it promotes responsible self-medication. It empowers our patients to increase their health literacy and to foster long-term health-conscious behaviors. There are 6 broad health conditions which were identified by the Royal Pharmaceutical Society, and these have connections with allergies, pain, skin problems, digestive disorders, women's health, and oral health. And they saw that when they reclassified products under these headings, there was a benefit to be derived by the general public. Importantly, and I heard Mrs. Jamot make reference to Vision 2030 and the strategic goal, this falls under goal number 1, which speaks to safeguarding access to equitable, comprehensive, and quality healthcare for the nation as a whole. So we can see that reclassification of medications enables individuals to treat specific conditions whilst having access to informed guidance, advice, and support, obviously, from the pharmacy team. And then we get to poll question number 3. Right. So we're just taking a little step back, see if persons were engaged and listening to that section of the presentation. Right, I see many of us have resisted the call of dinner. We're paying attention. All right, so we're moving into the last section of this presentation, looking at and for those of you who may have seen me use this image before, yes, it's an image that I like to use because I think it brings across my point precisely. Can someone indicate in the chat who is a pharmacist? This is a loaded truck. I think it's going through the Sahara. We just want to know who is a pharmacist on this truck. I'm seeing someone say the truck. No, we do carry a lot. We do carry a lot, but we're not the truck this time. All right. So in this case, pharmacist is a driver. We have the responsibility of taking all of these persons safely from point A to point B. And for those of you who sang the Buju Banton song, yes, driver don't stop at all. So we have 5 roles that we're going to look at. And I chose this picture because it's a little more in line with what we're familiar with as pharmacists, you know, the multitasking and doing 10 things at once. So in terms of initiating reclassification requests and the related activities, we've seen that in being able to propose the reclassification, pharmacists are able to act as policy advocates. They're able to ensure that the regulatory framework keeps pace with clinical practice and evolving consumer needs, and that is important. Mrs. Jamot made reference to the fact that as pharmacists, we're in the field, we're seeing these things day to day, and so we can inform that process. As the mandated presenter, the process also ensures that pharmacists are able to translate and input their practice knowledge into the proposed regulatory action. Additionally, we want to recognize the fact that pharmacists are able to play a central role in ensuring that other pharmacists will be able to handle the newly reclassified drug confidently, consistently, and safely. As a health educator and patient advisor, the pharmacist not only augments access to these drugs, but can empower patients in treating self-manageable or low-risk conditions. And of course, this reinforces the place of the pharmacist as an accessible care provider that has not shifted over the many years that they have looked at it. And also, pharmacists are able to fit into a role that many are familiar with, where the pharmacist can help to improve medication literacy, reduce unnecessary doctor visits, and strengthen patient autonomy. An educated patient is a patient who takes on the management of their particular conditions way more and with more information than one who does not have access to that information. Now, reclassified drugs may still carry risks if dispensed without oversight. And so the environmental controls remain critical. And therefore, it is the onus is on the pharmacist to ensure that the reclassified drugs are dispensed in line with the new legal requirements, the listing requirements, to operate within classification-specific restrictions. So you look at the quantity limits, you look at the storage restrictions. If it should be stored within a particular space in the pharmacy, that is where it is stored, i.e. the dispensary. To maintain documentation where required, I'm not sure how many persons are familiar, but in dispensing ECPs and OCPs, persons are required to make documentation. And if you don't have access to that particular manual, it is available on our website. Of course, pharmacists are charged with preventing unauthorized access or diversion of these listed drugs. And I don't need to go over this because Mrs. Jemmett indicated that pharmacovigilance reporting is very, very important. Pharmacists contribute to a feedback loop that helps to protect public safety and allows for adjustments to either classification or reclassification guidelines as it relates to particular drugs. They are able to see the dispensing patterns, and so they're able to give real world information as it relates to that. And finally, pharmacists are able, well, certainly they're the most directly informed stakeholders as it relates to the success or the limitations of reclassified drugs in the community. And so it is important for them to share that information, to support the reclassification process by making recommendations themselves, as well as to participate in fora like this, where they're able to provide feedback and strengthen the evidence. If it is not written, it doesn't exist. If it's not in a study, it can't have the sort of effect that we want it to. And so with that, I want to thank you so much for listening to my presentation this afternoon. Those are my references, and thank you so much. All right, do you have any questions?
Audio check 1, 2. All right, thank you so much. Round of applause again for the wonderful presentation by Dr. Langley. Dr. Langley, you hear me?
All right, I'm hearing you now, Sam.
All right,
My
wonderful.
apologies.
So we have some questions here. Let's see what we can do. Can a medical practitioner make a proposal for listing, please? I don't know if is that a question? Reclassification?
A medical practitioner can make a proposal, but a pharmacist has to present that.
Okay, all right. I have one here from a very good pharmacist friend of mine. Can list 2 OTCs be placed outside the dispensary area so the public can see them and purchase at will?
And I'm actually happy for that question. There is no such thing as OTC products based on the listing criteria that we've looked at. That exists in other jurisdictions, not in Jamaica. Here, and you notice throughout the presentation, I made reference to list number 1, list number 2, list number 3, list number 4. Now, list number 2 products are our pharmacy-only products, and they are to be stored behind the counter. And for persons who are familiar with pharmacies that have been in existence since about 2010, that have either been established, they've had some changes in terms of ownership, relocation. The stipulation is that list number 2 products have to be stored within the dispensary, not across from the dispensary, not at the cashier, but within the dispensary. So 1, no OTC products. We have list 2s, we have list, and I'm usually at pains to say to persons that when you look at a list 1 product, the idea is that, as I said before, it can be sold on a handcart downtown, it can be sold at a gas station in Crossroads. That's the sort of dynamic that is set up. All right, so I hope that answers that question.
Thank you very much. It does. What is the timeline for gazetting after completing all of the PCJ requirements?
That too is a very good question. That is the purview of the legal department in the Ministry of Health and the functionaries that, and I'm choosing my words wisely now, the functionaries that go about seeking to have that process completed. It's usually a little bit of back and forth because we have to ensure that what was submitted, once it's approved by the minister, it is accurately represented. However, that process in the recent past has been a little bit delayed, a little bit longer than one would want it to be.
All right, thank you so much. Where can we access the 6-step classification and 11-step reclassification process? Where can we have access to that?
All right, so you just had access to it. But seriously, these are all policy documents. And it goes to the point that we have been making, that there is need for regulatory reform and a real look at the legislation, because these documents, these policies are not captured in the legislation. They form a part of our policy documents. And so persons who approach the council to have reclassification done would then be exposed to the document. In terms of classification, this is a conversation that usually happens and a process that happens between the Standards and Regulations Division and the Ministry of Health, and the functionaries there are quite familiar with the process.
Thank you so much. This person is saying, good day, Dr. Langley. Any consideration by the council to have a vaginal antifungal, example, clotrimazole, as list 2?
Currently, there is no such application before the council, but as I have made reference to, the floor is open. Provide the information, provide the safety data, and it can be considered.
Thank you. Curiosity here. Can you give an example of a drug that went from list 1 or 2 to list 4?
Off the top of my head, can't think of one. However, and when I say can't think of one that you would be able to recognize, meaning there is a draft document that has been in circulation, which is not in law. So I can't make reference to that particular list, but there are items on it based on quantity and strength that would be moving from list 1 to list 2.
Thank you so much. Are you aware of medical practitioners crying foul with the movement of drugs from list 4 to 2, being that less patients are going to them and more coming to the pharmacists?
Short answer, no.
Okay. Has the draft list 2 been gazetted?
No, it has not. I believe in February or March of this year, it was sent out to the industry for feedback in terms of the content, anything that needed to be added, possibly items that persons may want to be removed. But I'm aware that that process is ongoing.
Thank you so
It
much.
has been projected, admittedly, but it's ongoing.
No problem. Since any pharmacist can apply, is there any obligation from that pharmacist to notify the distributor?
Of course, those rules would apply. You can't apply to relist a product that you are not in control of.
All right, thank you. Can the training of 75% be done by creating an online training program? Would that be approved by the council?
So many a reference has been made to COVID-19. Fortunately, online training is one of those gifts that we can point to, one of the very few positives that we can point to, which came from COVID-19. So a hybrid approach could be utilized. It's something, we don't have any current training activities going on now, but certainly it's something that would be incorporated, and it allows persons to have a greater reach instead of having to plan these physical training exercises all over the island. So definitely for the purposes of efficiency, it could work.
Wonderful. Amazing. If a brand drug is reclassified, are the generics also reclassified?
That is a great area that I was hoping would not have come up, but since it has.
No, man, we can skip it. I mean, oh no, jokes.
No,
Go
no,
ahead.
no, I can answer it, son. So once the active ingredient has been classified, all the products are reclassified. So in the case
So just
of
repeating, once the active ingredient is reclassified, then all the brands would be and the generics would be reclassified as well.
So the example we used in the presentation was tolnaftate. We also looked at levonorgestrel. All brands of levonorgestrel, all brands of tolnaftate are list 2. It is something that has generated a little bit of discussion every time this happens in terms of the process, the person who makes the proposal, and the impact that it has. But as it stands currently, I'm not saying that is what it will be going forward, but as it stands currently, that is what obtains.
Thank you so much. All right, I won't lie to you, we're not getting anywhere close. I have so many questions for you. I have one here. Are the OCP, ECP logs routinely checked by the council?
I'm going to say not routinely, but it's not something that persons should ignore. Once there is a challenge that arises, I often say to persons, it is what you have in writing that will serve to protect you. So not because the council is not examining that as a course of, doing the inspections, it doesn't mean that you ought not to protect yourselves and your practice by following through on that requirement.
Wonderful, thank you. Is there a policy being developed with sale of drugs by doctors and their assistants?
Short answer, no, not that I'm aware of.
Is it true that an antibiotic cupboard is no longer needed?
That's true. For many years, we have not asked for a designated storage area for antibiotics.
Okay. A good one here. Can all lists be made online? That way pharmacists can log in and see them?
It is a consideration going forward. Persons may be aware that the legislation that I made reference to, as a matter of fact, all of our legislation is available from the Ministry of Justice website. The updated version may not be there. However, I believe it was probably 2 or 3 weeks ago, I saw where the Ministry of Legal Affairs was actually looking to overhaul the access to laws. And so I'm hoping that in doing this and making it accessible online, the updated versions with all of the additions that have been made over a period of time, that those would be accessible. However, if you are not seeing them online, you can get physical copies of the law from the Jamaica Printing Service on Duke Street. And I'm aware that the Pharmaceutical Society also has laws for sale.
Thank you so much. Remind me, this is a question here, remind me, who regulates other companies outside of pharmacies that sell list 2 items freely, like on Instagram or at spas or wholesales or health food stores? Who regulates?
So that sounds like a loaded question. And I think the person knows the answer, that by virtue of the fact that these products are pharmacy-only drugs, they ought to be accessed only in pharmacies. And so you want to look at where those drugs are coming from in terms of the supply and where they're being offered for sale. And so that brings into that whole scenario, importation and offering for sale. When it comes to offering for sale to the public, clearly that would be the council.
Thank you so much. I have 2 questions I'll put into one. Essentially, it's asking, during the process of reclassification, so earlier this year, drug was put for reclassification, it's not yet gazetted. Does that mean that we can sell the drug under the new classification, or we have to wait? That's the question.
Conventionally, and as I have outlined, until it is gazetted, it ought not to be sold under the new conditions.
Gotcha. All right. So, final question. Where can we see the list of OTC and their classification? No, final question I'll ask. Where can we go to see the list of OTC and their classifications, understanding that there are no OTCs?
So the list 2 drugs as many persons will know, is a list of exemption. If you're not seeing it on list 1, list 3, or list 4, by virtue of exemption, it means that you are now assuming that it is a list 2 product. And of course, as pharmacists, we do not assume. We want factual information. And so that is why the council has been on a drive to get a printed list 2, which has a comprehensive listing of these particular products available. As it stands, that list has not been gazetted, but I am hoping and praying fervently that that will be done in short order.
All right. Thank you so much. Another round of applause. One's in the chat for Dr. Langley. What an amazing presentation. Next, we'll go to one of our sponsor spotlights before we return to our moderator. And the sponsor spotlight is by Health 2000.
Good day, this is Health 2000 Canada, or H2K, a generic pharmaceutical company proudly serving Jamaica and the Caribbean since 1999, bringing you products made with the best ingredients, delivering efficacy, safety at affordable prices. Breathing is easier with H2K Bronco Air Salbutamol 100 microgram inhaler. When you are coughing, wheezing, and feeling breathless, use H2K Bronco Air for rapid relief. Bronco Air rapidly opens the airways and relieves chest tightness, wheezing, and coughing, usually within 5 minutes so you can breathe more easily. H2K Bronco Air, an affordable, effective solution for the management of asthma and COPD. Keep Bronco Air close for the onset of an asthma attack. Breathe easier with Asabec beclomethasone 50 microgram inhaler and control symptoms such as wheezing and shortness of breath caused by asthma and COPD. Use Asabec to reduce swelling and irritation in the airways. Asabec does not replace your rescue inhaler such as Bronco Air in the onset of an asthma attack. When using Asabec, improvement may occur as soon as 24 hours. However, you should still continue to use Asabec even after you feel better. Control your breathing. Control your life with H2K Asabec beclomethasone inhaler. H2K SCSI azithromycin 15 ml suspension with 200 mg per 5 ml provides efficacy and convenience with its once daily dosing for children and the elderly. SCSI effectively treats upper respiratory tract infections, acute bacterial sinusitis and acute bacterial otitis media, pharyngitis, tonsillitis, skin and soft tissue infections. SCSI is not recommended for infants below 6 months of age. However, it is the only azithromycin suspension that provides a delicious mint flavor enhancing compliance. When you have wet, dry, or any cough, use Dawacough, an excellent mucolytic, expectorant, and bronchodilator in one. Dawacough contains just 2 mg salbutamol, 4 mg bromhexine, 100 mg guaifenesin, and 1 mg menthol in one great tasting syrup. Dawacough is excellent and effective in the treatment of reversible bronchospasm in bronchial asthma, bronchitis, pulmonary emphysema, or just in the symptomatic relief of coughs and catarrh in flus, cold, and mild throat infections, and any chesty coughs. The dosage for Dawacough is 2.5 ml 1 to 3 times daily for children 2 to 6 years, 5 ml 1 to 3 times daily for children 6 to 12 years, and 5 to 10 ml 1 to 3 times daily for children 12 years up and adults. H2K SK-Derm, a powerhouse combination of betamethasone dipropionate, clotrimazole, and gentamicin sulfate for the 3-in-1 effect. Team H2K thanks you for listening. We ask that you continue to support us by dispensing H2K and making us your generic of choice. We look forward to a bright future together in partnership. Have a great week ahead.
we have come to a point in today's CE that is just tremendous. I want to make it very clear that we have 965 Gazette devices online with us. Yes, I'm into the Gazette situation. I mean, Dr. Langley has left a lasting thing on all our minds. We went up to 1,000, and that is wonderful. We need to clap ourselves for that, to clap our participants, to clap our pharmacists. They need to send up the ones for themselves. I need to just give the final 3 names of persons who will receive gift baskets out of the 15, and that's Curtis Latibodair, Sheree Morrison Brown, and Lutz Marie Bernardo. And 15 baskets plus 1 will go out from Aventa. I want to call at this moment Dr. Tyrone Smith, before I totally close off my section, to present him. Thank you. Come, sir. To present him with a gift from Aventa. Doctor, it's been a pleasure to have you. You not only came this morning, but you stayed the entire day. And you spoke of partnership, and you not only spoke of it from theory, but you practiced it today. It is with great pleasure that we present you this little gift.
Thank you so
It's
much.
a pleasure. So as I bring my section of this fabulous and wonderful CE to an end, we learned what's in the air from Dr. Baker. We learned how in fertility management we can harvest and freeze our eggs as women. We also learned about surrogacy in Jamaica. We learned about, from Dr. Gemot, pharmacovigilance, and in particular that there is new update that we can report with ease through QR codes and emails and all that is technology would bring to us. Dr. Langley, she sat down at the driver's seat. That's what she did. And she drove the bus of updates on OTC classification. And she don't drive it home yet, because the amount of questions that are still awaiting her. But she took that bus to the point with such ease and calm, and she knows her stuff. Like a real general. No, me not on the street. I'm just telling you. She drive the bus home. And we thank you very much. I see Sam putting him hand on his head. So because guess what, Sam? I'm just thanking you guys for just bringing me up to date. I'm just telling you. It has been wonderful. Thank you. And Sam says I'm to say have a good day. Okay.
We would like to thank all the pharmacists, all the attendees who came out today. It was a wonderful session. We couldn't have done it without you. To our speakers, we only have one left in the room. Your expertise, knowledge was appreciated. You delivered well, and we will now take this what we've learned back to our practice. I myself have learned a lot, and I'm going to implement come tomorrow morning. To my esteemed moderator here, who has guided us skillfully through the session and kept us on track. Thank you, Mrs. O'Sullivan. To our Sam and his team, wonderful. We couldn't have done this without Sam. We look forward to another CE later this year, Mrs. CEO, next week. And do come again. Thank you very much. Enjoy the rest of the afternoon. We have one final presentation for Mrs. O'Sullivan. Thank you so much.
Bless you. Pleasure. Love you. Bless you. Yeah.
Thank you so much. Thank you so much, everyone. So, again, have a wonderful, wonderful evening. Remember that your quizzes will be in your emails later today. You'll have until Monday, the 30th of June at midnight, not July 1st at 12:01 a.m. Please take your time, look at the information. We'll share presentations with you once we get permission to do so, and you'll be able to do your quizzes. Have a wonderful evening. We'll see you at the next one. Bye-bye.